those here, we'll start in a few minutes. Thank you. We'll start in 2 minutes.
2 minutes.
Okay, we can start whenever you're ready, Joe.
I'm ready.
Would you like me to do an introduction real quick?
Sure.
Okay. Hello, everyone, and welcome to today's event, The Realities of Marijuana's Legalization on Public Health and Cannabis Use Disorder. My name is Orlando Cooper, one of the graduate assistants at IHEC, and I'll be your moderator. I am assisting Madison, the assistant director for the Illinois Higher Education Center for Alcohol, Other Drug, and Violence Prevention, and we are very excited to be hosting today's event. Before I hand over the microphone, I have a few housekeeping items to cover about today's webinar and the GoToWebinar platform. For those of you new using GoToWebinar, you will see the control panel on the right of your screen. This is where you'll find the question box that you can type and submit to at the end of the presentation. All attendees will be muted for today's program, but that doesn't mean you still can't participate. So without further ado, I'd like to introduce I would like to introduce today's speakers, Joe Eberstein and Patrick Foley. The stage is yours, guys.
Well, good morning, everyone, and thank you, Orlando, and thank you to the IHEC team and Madison for having us. This is kind of our season finale here, where we have a ton of information, so buckle your seatbelts because you're going to learn everything there is to know about marijuana products, legalization, retail sales, mental health, public health, drug driving, you name it. Um, Again, my name is Joe Eberstein. I'm a certified prevention specialist. I have over 12 years experience in the prevention system. I'm also a member of the SAMHSA Region 9 Prevention Technology Transfer Center. And I want to introduce my co-presenter for today, Patrick Foley, who's here in the office with me, and we're going to go back and forth.
Good morning, Orlando. Thank you for the introduction. We're looking forward to today's presentation. As Joe already stated, that we have a wealth of information. I'm really looking forward to you guys learning and engaging as well. So please utilize the question box at the end of Joe's presentation and mine. We're open for questions, and if you don't ask it, maybe somebody else was wondering it. So please put it in there. Even if we covered something and you want a little more clarification, we're looking forward to it. So please enjoy. I'll turn it back to Joe. Thank you.
Yeah, we love questions, and that's going to make this a successful training, is for you to submit questions in the questions box. After my presentation in the morning, I'll take some questions that are in the question box. So a little bit about my organization, the Center for Community Research. We are a 501c3 nonprofit group. We have a small staff, but we cover a county as large as 3.2 million people, a city with 1.5 million people, very diverse population. We have one of the largest Middle Eastern Chaldean populations. We have a large Vietnamese population in San Diego. We also have a large Somali population, and we have to do substance use prevention and make sure that we're covering all of these areas. So all of our work is culturally appropriate. And most of our materials are as well. So my main job is to be the program manager for the Marijuana Prevention Initiative. Sometimes I get people say, is that really a job still? You know, marijuana prevention, come on, it's legal. Why would you need to do any prevention around it? Well, I think after today's presentation, you'll realize that, you know, the products today are not the same as even 10 years ago. But I focus on youth specifically. And sorry for my East Coast accent, you know, youths. But youth use is different than adult use. And one of my main jobs is doing something like today, which is a webinar trying to educate and inform different people about this. And Illinois just went retail sales in 2020. So I'm sure there's a lot of questions from prevention people as to how they move forward in all of this. My organization also facilitates the county meth strike force. You can see their email here. It's composed of over 70 agencies, including local, state, and federal representatives. We put out annual report cards. I hate to say, but we've had some of the worst meth-related death rates recently, and it keeps climbing. We also facilitate, my coworker Marla Kincaid facilitates the Prescription Drug Abuse Task Force, which is also a multidisciplinary task force centered on collaboration, trying to come up with prevention strategies to deal with prescription medications and fentanyl, which is a really big problem both locally and nationally. So our objective today, and I know both Patrick and I have a substantial amount of time in both the prevention and treatment fields, working directly with clients and communities. I know you've probably seen a lot of people that give presentations and they talk and they really have great degrees and everything. But we work in the field. Patrick literally conducted a treatment group yesterday with most of the kids who are suffering from cannabis use disorder. So we know what the trends are because we are living it with our clients and our community every day. But we want you to be able to make an informed decision about marijuana after this presentation. Maybe with your own family, maybe you want to have a conversation with your children or with your husband or spouse or wife. Maybe your or their use is concerning. And maybe you learn something today that will make people recognize that this might not be the way they want to go. Um, Again, I want to reiterate the questions. There is no such thing as a stupid question. That's what we're here for. We are here for 4 hours. It's a long time. So put it in the chat question area and I will try to answer it, or Patrick, as best as we can. We have a really big agenda today. We're going to talk about the current landscape around marijuana, retail, decriminalization. We're also going to talk about how COVID has affected the substance use landscape. I'm going to talk about medicinal use, and I'm really going to just be very blunt when I talk about medicinal use because that's usually what I do. I'm very matter of fact. I will talk about the products because there are so many coming out each day. And then I'm going to tell you about some of the public health data we've been able to track both pre and post legalization. Patrick will talk about treatment and cannabis use disorder, some of the trends that he's seeing currently. I'm going to show you a 20-minute video of the Isaac News Conference that we did in May, which is the International Academy on the Science and Impact of Cannabis. These are doctors educating on marijuana use from a non-political standpoint. There's something very powerful listening to these doctors speaking very matter-of-factly from a clinical perspective about the effects of marijuana on health. I'm going to give you prevention tools. I'm going to talk about challenges, and I'm also going to discuss how we can create resources to meet the changing political and public health landscape around marijuana. So, diversity and inclusion, I know this term is thrown around quite a bit lately. If you work in a small city, a large city, a small town, this should already be a part of your work. It should have been at least, for as long as you've been doing it. You should have materials that are culturally appropriate. You should be listening to the community. You should be listening to the different communities that you have within the city. Not everyone feels the same issue is the same. One of my biggest things is that you should have staff that have lived experience. There's nothing that really concerns me more than having somebody come in and speak that's too polished, that never experienced life, that never had any kind of an addiction. I mean, I am very open about my own struggle. I'm an alcoholic. My dad was, he was the best man on earth. But when I go in and I speak at schools, which is a part of my job, not the whole thing, I'm okay with sharing that. I'm a member of the gay community. I'm openly gay. I don't mind sharing my struggles of coming out. But again, I can relate to the kids because I'm not afraid to talk about myself. And there's something powerful about not having those secrets, non-stigmatizing language. I know Patrick will talk about this, but we don't use the term addict. He's an addict, or are you clean? We use substance user. I hate the term clean because it implies that somebody using substances is dirty. No one's life is as perfect as their Instagram feed. So I just want everybody to be remembering that, but getting staff that have lived experience is really important. So we're going to talk first about the current landscape around marijuana retail sales. As I said, Illinois just went retail in 2020. And also we've just or are coming out of a pandemic. the first time in history we ever dealt with a pandemic by locking everything down, and what kind of effects that's having on substance use trends and mental health. And then I want to talk about who is the marijuana industry, because of course in this country there has to be profit made somewhere. So the industry, including the marijuana and alcohol industries, are making a lot of money because of the fear that's out there. People are self-medicating. So let's talk about the terms that we use around marijuana, like legalization. So legalization to me means that people are not getting incarcerated, and I'm all for that. I don't think people should be incarcerated for possession of small amounts of marijuana. Now, the term recreational, I have a problem with. And you can see here, these are some samples of recreation: fishing, camping, garden. I don't know if any of us go out on Friday night and say, I'm going to recreationally use alcohol tonight. I think we have to be very careful when we use these terms, because is pot use a recreation? Is it a tennis match? I don't think so. And then we want to talk about, retail sales. What are retail sales? Is that the same as legalization? Retail sales, you're setting up a for-profit industry to market, advertise, and sell marijuana. Sell it like cheeseburgers on the street corner. That's really what you're doing. So there's a difference between decriminalization, which is just not having law enforcement arrest anybody, and then setting up a huge monopoly around the sales of marijuana. So as of October 2021, this is the landscape for legalization in the country. And you can see the states in black here. Most of the West Coast, most of the East Coast now is going. You can see different states that are in different phases of this. Some are fully illegal, like Idaho and Wyoming. Some have CBD only, like Texas. Some are just decriminalized, like North Carolina. Some just have medical, like Michigan. I think that's Michigan, or no, that's Minnesota. And then you have medical and decriminalized in the darker green. And I wish they would have chosen other colors than green, because I can't really decipher the light and the dark. But you see Illinois here in black, legalized. So Illinois, I got all of this recently. In 2021, the sales from marijuana in Illinois were 1 billion, with sizable September numbers. There's a number of factors for this, and COVID is one of them. I don't know if your state declared marijuana an essential business like ours did. Illinois was the 11th state to legalize retail sales of marijuana. There's a couple of caveats to Illinois' legalization. One is the consumption lounges. You won't be allowed to smoke, vape, or consume marijuana in a public place. This was something that we were promised in California that is now overturned, and they're allowing consumption lounges. So I think you're going to be seeing an attack on your smoke-free policies. You're going to be seeing a push to have locations in downtown areas, which increases the risk of drug driving. Everything that the marijuana industry promised us, the public health, we don't want it around kids, doesn't seem to really matter now that profits are taking off. Just because something is legal doesn't mean it's safe. We see this with alcohol. I have a history of alcoholism. My dad passed away an alcoholic. Again, he was the greatest man on earth. He could conquer any challenge. One thing he couldn't conquer was the alcoholism. If we're really truly going to be doing something around prevention, we need to start young. We have data that says some of our kids are starting at 11. So if that's the case, then we need to start prevention and a healthy choices campaign in 9, 10, or 11. We definitely need consumer protections and product safety. I mean, you can go and see when I show you the slide, there's more protections around aspirin than there is for THC, CBD, or any of these cannabinoids. Excuse me. We also need compliance checks and minor decoy operations to make sure that these delivery services are not just dropping off a package of high potency marijuana to a bunch of adolescents. If we're gonna follow the science, then I think the age of access should be 25, because that's when the brain is fully developed. Now, I know people are going to say, I can't believe you're saying that, 21 for alcohol. I actually think the age for alcohol scientifically should be 25 as well. So let's talk about medicine. You know, this is a funny thing, but the cartoon, I'm sorry, Leonard, I can't prescribe marijuana for your boredom. It's not a medical issue. And this is kind of what we're seeing with the medical program here in the state. Anyone gets a card. The assessment to get a card is very easy, usually involves a Skype interview and a doctor looking at you saying, yes, you look sick, here's your card. Medicine is doing clinical trials and lab testing on animals. A full examination is performed by a doctor. A medical history is considered and medication interactions are considered. That's a big thing right now that's sending people to the hospital, drug interactions with marijuana. Cancer patients actually use less marijuana than the general public. And for those of you saying that's not true, here's the study. The cancer study published in the Journal of Cancer, and this was in August. Researchers at Virginia Commonwealth University Massey Cancer Center analyzed data from nearly 20,000 people over a span of 4 years and found that reports of marijuana use peaked at 9% for cancer patients compared to 14% among people with no cancer. As a doctor, if there's any doctors on, you have to ask yourself, are you going to tell your sick patient to smoke a plant with over 400 chemicals, which we only know about 4 of them of the 400? What about inadequate labeling? What about product uniformity? You know, one substance at one marijuana business may be different than another substance. What are you going to tell them? Take 3 gummy bears and call me in the morning? What potency, what dosage? Are you going to tell somebody with multiple sclerosis, how much do I need to smoke? How much do I inhale? Smoking in general has never been a good way to administer medicine in the first place. Another thing I would say from a liability standpoint is, were you trained in medical school to recommend marijuana products? If you haven't been, you're leaving yourself open to litigation. A patient can come back, and there have been examples here of a patient either having a seizure or dying. And in some cases, a doctor recommended marijuana. Marijuana for pain, I encourage everyone, either while you're on for the remaining time, go to the isaac1.org website. Again, if you don't believe what we're saying, these are a group of doctors that are non-political educating about cannabis. Now, when people say that I'm using marijuana for pain because it seems to be the number one choice, which is why people are using medical marijuana, the studies that we have found and that are on the Isaac website are for a certain kind of pain. So most of the studies that claimed improvement in pain were based on neuropathic pain. So what is neuropathic pain? Fibromyalgia, shingles. It's not traditional pain like post-surgical pain, sunburn, cancer. The studies that do show efficacy in marijuana as a medicine use very low levels of THC or CBD. We never see scientific studies where over 50% THC helped with anybody. And you definitely don't want to be using high amounts of THC with things like seizure disorders and mental health medication. If you do want marijuana as medicine, you can go get something like Epidiolex, which is one of the first direct derivatives from the marijuana plant, CBD, to an FDA-approved medicine. This isn't a synthesized version of CBD. This is directly from marijuana CBD. If you want to see the side effects of Epidiolex, they have a package insert, and you could read things like suicide, somnolence, shouldn't take with blood thinners like Coumadin. You know, labs cannot test high potency pot on humans because it would be considered an unethical study. So when people say, well, you know, we don't have those studies, well, you can't tell people to be part of a study where we're going to try and test how much marijuana will kill you. and then offer you a Starbucks gift card for being part of the study. There are FDA approved other marijuana medicines like dronabinol, nabilone, Sativex, which are mostly THC derivatives. Another reason I don't favor marijuana and medicine in the same sentence is putting off treatment that may have worked in favor of marijuana. I hear people a lot, especially kids, saying, I've had a pain for months and I just use marijuana for it instead of going to a doctor. Lumps, rashes, bumps, fatigue, nausea can be a sign of serious illness. So you probably want to go to a doctor and find out why. Just medicating the pain away, you could be preventing yourself from getting an early treatment that may be working. Making your own concoction and delaying treatment, hoping it goes away. So again, please tell people to go to their primary care physician or a walk-in clinic. Pain can be a sign of something. If you want to know what several medical association position statements say, here's just a small list. I mean, there are, I think, over 50. Things like societies like the American Academy of Ophthalmology, the American Academy of Pediatrics. I think one of the best position statements I've seen was from the American Society of Addiction Medicine, ASAM, the American Lung Association. And I will tell you, they're not very favorable to using marijuana as medicine. The American Glaucoma Foundation. So I want to also talk about the term dispensary that's thrown around. So when I looked up what a dispensary was, a room where medicines are prepared and provided. I think the term that we need to use for a place selling marijuana is a storefront or a marijuana business. When you look at some of these deals, I don't know if this is very medical. Super Joint Sunday, 15% off pre-rolls. Monday, I don't know if your doctor offers coupons for your blood pressure medicine. And I think, people in the medical field have approached me and said, I went to school for many years to be called a doctor, and I resent somebody calling something medicine when it hasn't gone through the same protocols as medicine. And there's no proper labeling, there's no purity, and you can recommend as opposed to prescribe. By the way, a doctor can't prescribe smokable marijuana at a dispensary, but they can recommend it. But a doctor can prescribe Epidiolex since it's approved. If you have a terminal illness, and I hear this one too, you're heartless, you don't care about people. If you have a terminal illness, use what you need. If marijuana helps you cope with severe illness or terminal disease, use it. Always consult a doctor to make sure that you're not making it worse. But I am not one of these people, and if marijuana has medical value, they should study it. But having a perfectly healthy 20-year-old with a developing brain using 86% THC every day is not a healthy alternative. So this workshop is very timely. The COVID lockdown has changed the retail landscape regarding not only marijuana, but alcohol. I mean, if you go on some of these food delivery apps, you can see all of the alcohol advertisements. It's easier to get alcohol than a bagel. Big industries are using economic fears to push increases in access and availability, promising more tax revenue. Public health and prevention are taking a back seat in favor of profits. Some recent disturbing policy decisions here have been around allowing pot consumption lounges, which are destroying our smoke-free policies. Pot declared an essential business during a respiratory pandemic. I don't know who came up with that or what doctor was consulted. That is the most bizarre public health decision I could possibly imagine. And then you have the industries wanting to increase hours of operation, 24/7 delivery, drop off at the corner. Is anybody checking to see if minors are getting this? I mean, during the pandemic, we kind of let a lot of things slip by. So lots of fear in this country. Breaking news, it's worse than yesterday. Everything's terrible. It's time to freak out. We were locked down for over a year and a half. So people are struggling. I've had my own struggles. I know my friends have had struggles. It's been a real heck of a year. There's fear, isolation, depression, economic worries, 24/7 bad news, and our kids have been connected to the internet and their phones this whole time because they were prevented from coping skills that they used to do, like going to the beach, the gym, the yoga studio, whatever, the park. So people are turning to substances in record numbers, and you could see that here with US overdose deaths are at a record with 93,000 in pandemic last year. It far eclipsed 72,000 drug overdose deaths reached the previous year. So things are going in the wrong direction, and fentanyl is leading a lot of this. Here are some statistics in our own county. We had a 51% increase in all accidental, illicit, and alcohol overdose deaths. We've had a 45% increase in deaths due to meth, a 205 increase in fentanyl. Now that I know when I'm saying these, it's hard to imagine, but when you're putting these signs on the front lawn of the county building to mark Overdose Awareness Day, and you meet the father of the youngest victim who was 13, it puts it in perspective. This was the first time I saw on one of these placards a 13-year-old that died of fentanyl. And it was just from the child who went to college and was offered a pill, and they took that pill. They weren't frequent substance users, and that pill unfortunately had a lethal dose of fentanyl in it. We've had over 970 overdoses, and I hate to say this, but as of August, we have already reached 970, and we're set to double that number for next year. This is a horrific time right now to be experimenting with substances. Declaring pot an essential business, I can't say this enough. The only people that this benefited were the marijuana industry or Altria Group, which used to be Philip Morris. I'm going to introduce you to them in a few slides. But I can't imagine how declaring marijuana an essential business like a pharmacy or a healthcare facility, I don't know, and I can't imagine. And I put two media pieces out in the beginning because I wanted my name in the historic records when somebody looks back on this and say, what a bizarre decision to declare a smokable substance an essential business during a respiratory pandemic. And we know now the studies are coming out that smoking and vaping are risk factors in developing more severe forms of COVID. Again, COVID is a respiratory illness. Why on earth would we encourage people to smoke or vape during that? You know, pot businesses had the same status as healthcare facilities. Was anyone in public health consulted? And I don't know. I ask these questions. I have friends all over the state, and I don't ever hear an answer back. We also have irresponsible public health decisions now in California being made with no regard for public health or children. Here's an example of the California State Fair, which the state sponsors this. They're giving an award for the marijuana product that is most likely to produce psychosis and dependence. The award will recognize flower in 5 categories with the highest concentrations of 2 cannabinoids, CBD and THC. I don't know who was consulted from public health, but this would be equivalent to going to a fair and saying, we are going to reward people that come up with the strongest alcohol, most likely to cause a DUI on the freeway. Again, when I try to send an email about public health, I get crickets. We've had the worst year for DUIs in 2021. We had 35 people, unfortunately, killed. DUI shouldn't even be a thing anymore with all of the rideshare programs that we have. There are so many choices. You know, more than 30% of our DUIs in San Diego involve cannabis alone. And I'm going to tell you or talk to you about the term cannabis versus marijuana when I talk about the products a little later. So the only ones profiting from this, ironically, is the marijuana industry, which one of them happens to be Altria Group. So you can see here, cannabis sales increased during COVID. Findings from Alaska, Colorado, Oregon, and Washington. Wow, how ironic. You declare something essential and shut everything down. Of course, it's going to be a banner year for the places that were open. Doesn't take a brain surgeon to know that. Taking advantage of the times, COVID is helping make 2020 a record year for cannabis sales. The white paper shows a 2-week spike in cannabis sales in March, around the time the US started to react to COVID and stay-at-home orders started to go into place. A good bit of the sales spike is likely due to panic buying by customers who were unsure when they would be able to access the dispensary again. And we saw this. I was at a dispensary. They were doing a very brisk business. Record sales. US cannabis sales hit record 17.5 billion as Americans consume more marijuana than ever before. The coronavirus was good for some industries and ruinous for others. Well, of course that's the case when you shut some of them down and leave some of them open. For cannabis, 2020 was a breakout year. Legal sales across the US. 14 states allow adult use, 36 allow medical, and they're making billions. So who's making billions? The same industry that brought us tobacco and cancer. The same people that brought us Marlboro and Virginia Slims. They just renamed themselves from Philip Morris to Altria Group. And they are not hiding their plans or intentions to enter the vape and marijuana markets. I mean, they keep putting out news releases. These are the people that you're filling their pockets with money. This is the Altria Advisory Board. So when you think next time, oh, cannabis is good for my community, these are the people that you're making money for. You can go, and I just pulled this off, and they're very proud of this, that, they're backing the sales of marijuana. Well, they were taking a beating with cigarettes because they were exposed that they were hiding the cancer risk. So, of course, they were losing money in the early 2000s. They're retooling to enter the vaping and marijuana market. How COVID affected youth outreach? Well, it basically shut it down. I mean, for a while, we didn't know what to do. Schools were shut down. Sorry, we're closed. In-person advocacy at schools stopped. Presentations and face-to-face interactions stopped. After-school activities gone. Beaches, gyms, movies, churches, yoga studios. The only thing open, ironically, was marijuana dispensaries and gas stations and liquor stores. Prevention had to evolve. We went to virtual meetings, no in-person dialogue, working from home and dealing with kids, entertaining them, dealing with kids that were 24/7 online. You couldn't do any in-person advocacy. You couldn't go to the Board of Supervisors and speak. A lot of policies were passed when we couldn't adequately advocate. Usually when something substance use related comes up on the agenda, we bring the kids in, and it's powerful for the supervisors to see the kids. We weren't able to do that. We were limited to submitting e-comments and calling in. Lots of screen time for our kids, endless hours on the computer, no in-person communication, hours to scroll and get anxious, 24/7 bad news. Things are worse than they were yesterday and getting worse. Why do we think we're having these substance use issues now? Remember, our children are watching us. They're watching the decisions we make. Adult use affects kids. When we open up an industry and they see a billboard or they see the normalization, it affects their use patterns. Policy decisions affect consumption. Billboards and advertisement affect behavior. Increased access to potent products affect the health of our kids. And then normalization of marijuana storefronts and businesses affect our community. I keep saying this at our own Board of Supervisors. Please remember, this is the next generation that we're trying to help stay drug-free. Here's the products. I can tell you that I've been in a lot of the marijuana businesses or dispensaries, whatever you want to call them. They look like Apple stores, some of them. I'll tell you, they're making a ton of money, and they're not shy about their best-selling product, which is not, ironically, 3% THC. The best-selling product was 86% THC. That is an enormous amount to be consuming in a vape pen every day. Let's go back and talk about naturally growing cannabis, because I get this question a lot. You know, marijuana is natural, it can't hurt anybody. The marijuana of even 100 years ago doesn't exist anymore. Marijuana grows indigenously in Central and South Asia, places like Afghanistan and Pakistan. It needs a windy climate that spreads seeds. It's known as weed because it's an invasive plant. You know, before anybody knew there was cannabinoid chemicals in there, people thought it was a pain in the neck getting into crops. Naturally growing cannabis in the forest has very low levels of THC, maybe 3 to 5%. And when I say THC, I'm referring to the main psychoactive cannabinoid chemical, tetrahydrocannabinol. So you can actually modify, I know many people know this, can modify the THC potency and CBD through genetics, light levels, strain. They play a major role in potency levels. So let's go over the terms. When I say weed, or people say weed referring to marijuana, it's a general term for any plant growing where it's not wanted. Well, that's an old school one, because nowadays people want this plant because it's making them money. Cannabis refers to the genus of flowering plants, and the species of cannabis are sativa, indica, and ruderalis. Now, ruderalis is something new that many people haven't heard of, because scientists are still wondering whether it's a subspecies of cannabis or its own species. And that's because it has very little amounts of THC. You can see the leaf structure. Sativa is a longer, skinnier plant, and usually hemp is derived by this. Because of that longer, skinnier leaf, you can get cordage and rope and clothing. Sativa is known for, excuse me, sativa is known for having higher levels of THC. Indica strains are known for having CBD or higher CBD, generally a fatter leaf. And then we have ruderalis, which is very minimal THC. You can see the plant structure is very different. When I use the term marijuana, and some people say, well, that's offensive, that's this, I'm using a term that refers to a portion of the cannabis plant that contains high levels of THC. And that's what we're seeing being sold in these marijuana storefronts. So I'm going to continue to use the term marijuana because cannabis is incorrect. Then we have hemp, which is industrial use, very little THC used in that, but still people are managing to make extracts out of the minute amounts of THC in hemp. Supposedly hemp has 0.03% THC, but hemp in general has been farmed to make clothing, textiles, and paper. So there's no naturally occurring gummy bears with 86% THC in the woods. And I know this is meant to be funny, but when I hear people telling me that it's natural, it just looks so weird. I mean, there is nothing natural about THC at 86%. Even in my day in the 80s, the marijuana was maybe 5% THC. The stuff we're seeing now wouldn't even recognize the cannabis growing in the woods. So THC, or tetrahydrocannabinol, is a cannabinoid chemical responsible for the high. This is the one I'm mainly concerned about. These chemicals can be modified to enhance potency, and we know that's happening. How do you do that? Crossbreeding, genetic modification, extraction methods, sometimes using butane. They can all increase potency. Unfortunately, it can interact with prescription medications, driving, and mental health medication. CBD actually counteracts the THC high. And in naturally growing cannabis, there's a certain amount of THC and CBD. Now, when you are just extracting THC, now you're taking away the moderating factor of the CBD and you're getting an incredibly high amount of psychoactive substance. It can have more of a sedative effect, which I wouldn't recommend people taking CBD and driving. It can also be modified or enhanced. And there is FDA approved medicines coming out around CBD that help with a certain subset of seizure disorders that's very rare in children called Lennox-Gastaut and Dravet syndrome. Excuse me, I'm going to take a drink. So there's about 60 or so chemicals that we know nothing about that are cannabinoids in marijuana. But I can guarantee you, you're going to hear about them. We know little to nothing about CBGA, CBDA, CBGVA, THCVA. I guarantee you scientists will learn to modify these and sell them on the market. Very low potency is not a popular purchase item. And I confirm this with the owners of a very popular dispensary. Nobody's schlepping down to the pot store in the rain to pick up a 5% THC. They're getting the 86% mostly in vape cartridges like Stizzy or one of these vape pods. The most common reason for using when people do come in for medical is pain. And the average consumer is a 35-year-old white male with self-diagnosed pain. There's nothing natural about today's pod. Again, they're GMO created products, high potency, oils, waxes, gummies, pods. I mean, you look at this, you say, this looks so far removed from the naturally growing plant. Edibles can react differently. It can take longer to feel the effects. I would not suggest any marijuana users for the first time going to an edible. There can be more of a head high. In some cases, users report highs from 8 hours to a day, can interact with driving and prescription medications. We are starting to see the ramifications of little to no consumer protections. We have a wrongful death suit filed in California over a woman who died after ingesting THC-infused edibles. One of the statements that the lawyer said was these companies disguise and market their products as safe, fun, and healthy, going so far as to represent to consumers that the products deliver the well-being and relief to all of those that seek it. What they don't tell consumers is that the use of their products carry extreme risk of serious injury or even death. And there's a lawsuit, and I know the industry is scared because I see this on all the blogs. This could potentially change the industry by adding, in a good way, consumer protections. Testing of products have been a failure, actually. Nearly 1 in 5 cannabis products fail testing. Inaccurate claims on the package, pesticides, microbial impurities, moisture. If you have a weakened immune system and you're getting a smokable cannabis strain that has mold or E. coli, you can get a fungal infection in your lungs and that can be terminal. So you got to be very careful. Even the legal market is having problems with purity. Where are the consumer protections? There's more consumer protections around aspirin. Look at this. Facial swelling, hives, asthma, shock. There's nothing for THC and CBD. No driver warnings, mental health, drug interactions, dependence, must be over 21. I can go in and virtually get it, and there's nothing telling me that it may interact with my over-the-counter medications. There's new products coming out with no testing. These are from hemp, surprisingly. Delta 8, THC, Rick Simpson oil. CBD is sold all over the place now, even at gas stations. How do you know the label is accurate? A lot of people thinking that they were taking CBD are tested at work and they're coming up for THC. So here's the difference between hemp and marijuana. I get this question a lot too. So hemp and marijuana look similar. If there was a pickup truck driving down the road with a truckload of hemp or marijuana, a police officer probably wouldn't be able to tell the difference. I mean, hemp has longer leaves, and the reason is because it's been industrialized for use as paper, cordage, and clothing. There are minute amounts of THC in hemp, though, and CBD. Now, marijuana here, you can see there's bulkier leaves, higher THC, but really, if I wanted to tell the difference between the two, I'd have to look inside the chemical to see the chemical structure, look inside the plant. We basically had marijuana legalization when the Farm Bill was passed in 2018 because there are all the same chemicals in hemp that there are in cannabis. And now we're seeing new chemicals that are being synthesized to get around the federal illegality, like THCP, Delta 8, all from hemp, all synthesized. And if anybody wants to know, the CDC put out a health advisory about Delta 8. Specifically in the Michigan area, a person or two people had a seizure related to using Delta 8. It's very powerful. So look up the CDC advisory. That happened September 14th of this year. Take a little water break for a minute. Then we have spice, which is often referred to as fake weed. There's nothing weed-like about it. It's a man-made chemical sprayed on plant material that is meant to look like weed, but it's called Damiana leaves. The Damiana leaves themselves are not psychoactive. It's what you spray on them. And this is 100 times more potent than marijuana. You can usually tell somebody who's having adverse effects from spice because they are ripping their clothes off, excited delirium, seizures, coma, and even death. Excuse me. Public health, I want to talk about because I went over the products. I want people to realize that now that big industries are involved, there is nothing really natural about today's marijuana. But what kind of an impact is that having on public health? So what do I mean by youth? From my profession standpoint, I'm funded to work with youth ages 12 to 25. Now, I want to use the scientific age for brain development. And since the brain continues to develop until 25, then I want to keep kids away or prevent them from using until that age. And the reason is, and here's a sentence I want people to remember, when you look at a 22-year-old, you say, well, they look like an adult from the outside, but their brain is still not fully developed. Recent research has found that adult and teen brains work differently. Adults think with the prefrontal cortex, the brain's rational part. This is the part of the brain that responds to situations with good judgment and an awareness of long-term consequences. Teens process information with the amygdala. This is the emotional part. Well, guess where you find most of the cannabinoid receptors? In the amygdala. This is why kids and youth use is different. Recent neuroscience has pinpointed a wealth of cannabinoid receptors in the amygdala, and THC targets those. Marijuana or cannabis is filled with cannabinoids. And that's why during this time of development, we want kids to develop naturally without affecting their endocannabinoid system, introducing all of these chemicals from marijuana. That's as simple as I can put it without breaking out the MRIs. Again, youth use is different than adult use. I want everybody to remember that. When you're talking to your son or daughter and you're my age, remember the products are substantially different and the science is catching up to the public health effects. Also, your dopamine system, people kind of gloss over this. It's like your body is the best chemical factory, but it likes balance. So your body can produce all of the chemicals it needs, serotonin, adrenaline, dopamine. When you start introducing outside chemicals, your body stops producing some of its own. We see this when people or guys use steroids and they take testosterone. What happens? You can shut off your own testosterone production. This happens the same when you start bombarding yourself with the happy chemicals that increase your dopamine level, the THC. When you start operating at that high level, your best day in the world, marriage, childbirth, graduation, still isn't enough to compare with that high. And what happens with people is they need either more to maintain that high or they graduate to other substances. My take on the gateway theory is you can build a tolerance for substances causing you to seek other substances to get a similar or increased effect. I know people don't like, well, it's a gateway, marijuana. I believe it's a gateway because it's probably the most accessible drug while kids are young. Another gateway or other ones are tobacco, alcohol, and even pills now. Again, when you are bombarding your dopamine system, sooner or later you're going to build up a tolerance and you're either going to start polysubstance using or trying to find products with higher levels of psychoactivity. So please collect public health data. If you're in a state like Illinois 2020, try to get the data both pre and post legalization. Things like ER data, poison control, medical examiner. I want to just take you through some of the data we've collected locally. This is the 1 million puffs study, and it looked into how frequently people who use vape pens are using them. So this said the median number of puffs a day that people are using in a vape pen are 132. That is a lot of 86% THC to be puffing 132 times. I would encourage everybody to look up this 1 million puff study. It was very eye-opening. We know we have a vaping epidemic in the country. You can see here from Monitoring the Future, they have the highest rates of vaping in their history, their 45-year history. I use Monitoring the Future quite a lot when I want to look at national data. But both past 30-day and past year use has increased. We have a Juul lawsuit, and I want everybody to write this down. If your school district was part of this Juul lawsuit, then you're probably going to get money. And this was basically because of Juul's deceptive marketing practices in the beginning that made vaping an epidemic. They said all the time they were just trying to get people to quit traditional smoking, yet they were putting ads out like this that were targeting youth on Instagram and Snapchat. So I know San Diego is part of this lawsuit. You might want to check and see if your local school district. I know North Carolina just got $40 million. Treatment admits, and Patrick is going to talk about this. He's the expert on substance use treatment. But we have marijuana as the primary drug of choice for youth ages 12 to 17 in county drug treatment. The changes we're seeing are mostly in females now. We see an increase in females going to treatment, but it has been a problem mostly for young men at a higher rate at 86%. Poison control calls, we've seen a 242% increase in poison control calls since 2011. And again, this is probably from edibles and other chemicals that are coming out. People don't know what the effects are, or the high is 2 days, 3 days long. You don't know what to do. We sadly have 39 ER visits a day in San Diego related to marijuana. Things like cannabinoid hyperemesis syndrome, psychosis, mental health issues, accidents. We still have e-cigarette and vaping associated lung injury. We have 62 local cases. Very hard to diagnose during COVID because the symptoms are so much the same. 11 is the age of first use for our justice-involved youth. 16% of our existing 51 marijuana storefronts with a known address are breaking the law and are within 1,000 feet of a school or a park. I would also encourage you to track your dispensaries. And then another sad number is, according to our medical examiner in 2020, over 50% of our suicides here in San Diego were THC positive. 30% of the DUI drivers in 2021 were THC positive alone. 35 people died in DUI crashes, and we've seen emergency room discharges. So you're probably saying, well, how does this affect me? I don't use. We recently had a patient wait 14 days in ER to be seen. And can be confirmed by Dr. Renette Lev, who's our chief medical officer, works at one of the hospitals here locally. When people say, well, 40 ER visits for marijuana doesn't affect me, our resources are limited. ERs are at capacity. So especially during COVID, nurses and doctors are leaving because they're so stressed out. I was told by my pharmacist recently, they don't have enough staff, so they only opened up the drive-through. They closed the inside. Mental health and suicide, there is actually a subset of psychosis known as cannabis-induced psychosis. Dr. Catherine Antley, which you're going to see in the video after Patrick goes, is an expert on this. It's eye-opening what she's going to say. The numbers of suicide in Colorado are skyrocketing, and this is a story that isn't being told. And I talked about our own suicides here. Cannabis-induced psychosis, hearing voices, people plotting against you, isolation, paranoia, delusions. I can't tell you how many times Patrick and I have talked to kids who said, my neighbor is out to get me, my neighbor is following me, I had to be in the house for 2 days because I hear voices, they're plotting against me. People smoking 86% in a vape pen all day long, isolated, and they may have a genetic history of mental health. They may have dual diagnosis. There is a variant gene that can predict whether or not people will get a severe form of this cannabis use psychosis. And it is called the AKT1 gene. One study found that the risk of psychosis among those with this gene variant was 7 times higher for those who use marijuana daily compared with those who used it infrequently or used none. What does this mean? This means if you have this gene and you smoke, specifically in adolescence, you're 7 times at a higher risk for developing cannabis psychosis. The problem is we don't have a test yet to see who has this gene. Hopefully they'll be coming up in the future with a test. My advice is if you have any mental health issues in your family, you probably want to stay away from marijuana. Pregnancy, people ask all the time, please go to the American College of Obstetricians and Gynecologists. They have a great poster in English and Spanish that you can put up in your healthcare facility or anywhere, and it kind of breaks down the effect of THC on the fetus. E-Valley outbreak, again, I said there were 62 local cases. I'm sure there's cases in Illinois. The current pandemic, COVID, it is easy to misdiagnose E-Valley, and I don't know if we're capturing all of these. E-Valley is a diagnosis of exclusion with a history of vaping and responds well to steroids. One of the projects we're working on is this drug interactions project, and it involves giving out informational info cards at pharmacies to talk about drug interactions that involve THC and CBD. I am going to click to the video, and I hope you can hear it. It's a little low. There's nothing I can do about it, but it gives an overview of the media event that we had. So here is Dr. Lev.
Every day. Patients present with various conditions, one of which is interactions with prescription medications. Patients are simply not aware of the dangers of mixing prescribed medicine and cannabis, both marijuana products, THC, and CBD. For example, during a recent shift to the emergency department, I cared for a 65 64-year-old man who came back to the hospital for the third time for internal bleeding. At this time, each time he came to the hospital, he had blood transfusions, had endoscopies, looking with the camera to search for the bleeding. And finally, the cause of his revolving door to the hospital was discovered to be a medication interaction with cannabis. He was on blood thinners for his heart stents, but he was also taking recreational marijuana that was interacting and making him more prone to bleeding. Blood thinner medications become more potent when mixed with THC or CBD. Lack of consumer protection and proper labeling has left consumers at risk of potential harmful consequences. Another common drug interaction is the additive effect of pain medications, anxiety medicines, depression medicines, and sleeping pills. They can interact and cause oversedation. An example is a gentleman who came into the hospital because he couldn't sleep and his family gave him some hot brownies that helped him sleep, but now he couldn't wake up. And he had to be admitted with encephalopathy caused by these drug interactions. Our project on cannabis drug interactions will do two things. It will provide consumers information on drug interactions, and it would also evaluate whether the public is interested in receiving such consumer protection information in the future. Drug interaction cards every prescription with our partner pharmacies. We will distribute 12,000 cards in English and some in Spanish to 17 pharmacies in San Diego County. Each information card includes a link to answer 4 simple questions to evaluate whether the project is beneficial to them. And we really want people to complete the survey, and so we will incentivize folks that whoever completes the survey may be entered to win a $100 Amazon gift card. And with that, I will pass on to Dr. Simon Ho.
Thanks everybody for joining. My name is Saul. I'm a pharmacy supervisor here at Sharp's Pharmacy Santee. We're happy to host the event here in front of our pharmacy. The Santee Sharp Facility Pharmacy is one of our 8 pharmacies that will be participating in the drug interaction project. Our other pharmacies are located around San Diego, in downtown, Chula Vista, Rancho Bernardo, Sorrento Mesa, La Mesa, San Diego, Maine, and Otay Ranch. According to the latest San Diego data, there were 29 cannabis-related murders. Some of these can be prevented by awareness of drug interactions between cannabis and medications. Currently, there are few or any pharmacies around the county provide drug interaction information with marijuana products. That's why Sharp Facility is proud to be a participant in this consumer protection project. We are not here to say anything about using cannabis one way or another. We're simply here to increase awareness that just like how drinking grapefruit juice could interact with important medications, cannabis could potentially do the same thing. And we're here to bring this very important issue to more people, more patients around Greater San Diego and hopefully around Asia as well. Our patients will have a chance to win $100 for answering simple confidential questions such as, were you aware of drug interactions between medications and marijuana and cannabis products? And would you want a warning if your medications have a serious side effect with marijuana and cannabis products? The survey will help us determine if the public wants this type of drug interaction. Thank you everyone for joining us again today, and I will now pass to Dr. Arnold Patel from Scripps.
Hello. My name is Arnold Patel. I'm the Director of Pharmacy Services over at Scripps Health, over ambulatory pharmacies. I'm really happy to be part of this collaboration with UCSD, Sharpie's DLE, and One's Pharmacy in this important project. Marijuana is legal in California, but what a lot of people don't know is that it's not safe for everyone. People should be informed of drug interactions with THC, CBD, and their medications. This is why 3 of our pharmacies will be participating in this drug information project, including Scripps Ambulatory Pharmacy, Scripps as well as Scripps Pharmacy. Our pharmacists receive training on cannabis drug interactions as well as various departments. This is related to marijuana. They'll be encouraging clients to participate in the evaluation to determine if our customers are interested in this information. I will now pass this on to Dr. Don. pharmacy director at Allen Pharmacy downtown San Diego. Our pharmacy clients are vulnerable and have complex medical and mental health conditions. They may be on multiple prescription medications. They're often not aware of the drug interactions that exist between their medications and marijuana. That is why we're eager to participate in these projects to raise awareness among our patients and hopefully prevent further hospital visits. Pharmacists have a unique job that requires disseminating important information about medications. It is quite common to see on prescription labels do not take with alcohol or other drugs. Unfortunately, marijuana use is often overlooked. This info card will help us understand the level of readiness the public has to bring information like this. Our pharmacists have been trained in answering questions related to this project and hope that this project will spark an ongoing conversation about patient safety and cannabis use. I'll now pass this to Joe.
Good morning, everyone. My name is Joe Emerstein, and I am with the San Diego County Marijuana Prevention Initiative Center for Community Research. It's very inspiring to have 17 local pharmacies participating in this project. Probably one of a kind in Illinois, one of a kind in the United States. We greatly appreciate and admire their readiness to provide a new type of consumer protection that may be the first of its kind. Lack of knowledge around this issue is causing people to end up in the emergency room, and that's a fact, to the tune of 29 marijuana emergency-related visits a day. You know this because community research tabulated that information and got the data. With this project, up to 12,000 people will receive information about drug interactions between cannabis products and medications. Patients will be referred to drugs.com to use as a resource to check for dangerous drug interactions between THC, CBD, and their own prescription medications. On the information card, a QR code will direct patients to fill out a quick survey. The information gathered will help us understand what types of information are useful to patients and where the gaps may be. We have instructed pharmacies to direct further questions that patients may have to the MPI website at ccrconsulting.org/MPI. It's also listed on the info card. Thank you for coming, and we'll now open it up for questions. Thank you. So this is the drug interactions insert. It went with every prescription filled at 17 local pharmacies. It encouraged people to visit drugs.com to check and see what medication that you're taking may interact with THC, CBD, things like Coumadin, things like anti-anxiety medications, pain medications. What we're really trying to do is get a discussion around consumer protections now that things have opened up substantially with retail sales of marijuana. If anybody wants more information about the Drug Interactions Project, we made an FAQ doc. I can share it with Orlando and Madison, and maybe you can implement the same strategy in your city or state. It's one way to get the consumer protection conversation out there. Driving in marijuana, there seems to be a pervasive belief that marijuana makes you a safer driver. This is really dangerous, specifically for our kids. When we get surveys back from the California Healthy Kids Survey, it always seems to be that kids think that it's safer to drive. They pack their friends in the car. You actually have slower reaction times, diminished alertness, and reduced self-awareness. There are going to be new saliva tests that'll be able to check the levels of THC. One of the things that is very interesting during a field sobriety test, and you can see here in this picture, is something called nystagmus with drug recognition experts or police specifically trained in recognizing people that are intoxicated. Now, generally with alcohol, we see this involuntary eye movement or nystagmus. One of the things that they don't see with marijuana is this involuntary eye movement. But we are trying to advocate for more drug recognition experts Usually these drug recognition experts can spot what drug the person was taking before the urine or blood test is taken. We shouldn't even be talking about drunk or drug driving anymore with all the rideshare programs, Lyft, Uber. I mean, let's use them. Seriously, let's use these places. I mean, there's dozens of them. Getting in a car now is just irresponsible, knowing you're going to get intoxicated or you've been using an intoxicating substance. Work-related injury I wanted to cover too. The American with Disabilities Act provides no protection to a worker if their employer fires them for using cannabis for medical purposes, even if the worker never uses marijuana during work hours. This lack of protection can also mean that an injured employee's workers' compensation claim could be denied. So make sure that whatever you're using, it doesn't interfere with the job, because this means that if you say, well, I'm using medical marijuana, you're still not covered. Because again, that term medicine is really a political term instead of a factual term, like I discussed earlier when we talked about what a medicine is. Disposing of vaping devices is another big problem. I'm not sure if everybody's aware, but these devices are considered hazardous waste. You're not supposed to be throwing them in the trash. If we're encouraging teachers to take these away or confiscate them, they need to have a safe handling protocol. Both the battery and the cartridge is considered waste. You don't want to touch the vape liquid. Liquid tobacco is a neurotoxin. It gets in through the skin. Make sure, and this is from our California Department of Public Health, that you wear gloves, that you put in a box that may be fireproof because the batteries are known to explode, and overall have a written protocol so that your staff is protected. Again, don't throw these in the garbage. Take back day also allows for some of these devices to be taken back. They want you to remove the battery. I would use gloves. Take back day just happened October 23rd here. And this is going to be my last slide before I transition to Patrick. I encourage everyone again to look at the ISAC website. It is a nonpartisan, non-political group. You can get on their email list, isaac1.org, and you can get medical information. They're having a webinar series. But on that note, I'm going to take a break and I'm going to hand it over to Patrick. But actually, I'm going to take whatever questions I see first. And I don't see any questions. Orlando, am I missing any questions? I don't see any. I don't know if you have access to that.
There's one question, and it says,
There is.
will participants have access to this PowerPoint presentation afterwards?
Yes, I share all of the materials with the group. So I will send it over. It's probably going to be too large to send, so you might have to create a Dropbox for Patrick and I to put our presentation in.
Okay.
Okay, I'm going to transition over. Do you want to try and do it? Do you want to do it? Escape. Okay.
Good morning, everybody. Patrick Foley. Joe, thank you for that presentation. Joe is fun to follow. He has a wealth of information, and I'm looking forward to my two presentations today. So that being said, I'm going to jump right in. I've been in the treatment world for around 22 years, but as a professional for the last 20. And my story is fun and unique in a way that the guy that got me my job in treatment, I wasn't looking for a job in treatment. I was looking for a job where I could actually pay some of my bills. I was very young, naive, and a gentleman asked me if I wanted to work at a group home. And I said, sure, why not? And the group home experience started my treatment journey. And that was in 2003. So I was in an inpatient adolescent treatment facility that was a mandatory 21-day facility. So this is 24-hour work. This means that there's 24-hour staff. So going in on my first day, I just want to share with everybody in the room that my first group was in the second hour of my day. So I've been running groups one-on-one with adolescents since 2003, and my first group kind of went like this. Here's your topic. Here's the booklet. They all have booklets. It starts in about 15 minutes, and there I was. So I don't remember their faces. How could you? I don't remember the topic. I will say that I still utilize the company that created the booklets because it's evidence-based, and I'll talk about that more later. But why I brought up that wonderful experience is, may I never forget that first time I did group and how excited I was to be at work, how excited I was for that new experience, and that dawned the work that I do today. I learned that it was my life goal to help people, that I was meant to be in those rooms to help people change. We often in treatment use terms like, you know, the light came on. We had that aha moment. And people in treatment tend to have that moment of clarity, they call it, where they say, you know, I don't know if my best thinking is great, but I know my best thinking got me here, and I don't know if I like who I am and what I've been doing, but hey, here I am. So the goal for treatment professionals is to meet them on the other side to say, hey, welcome. You know, this is a safe place. Sit down. It's great to see you. Hey, what'd you do today? And then start, you know, the group or the process of that recovery. I was a treatment director for 10 years. So my stint in inpatient was about 2 years. I was a manager of that facility for the second part of that. So I went from never doing a group to about a year later taking over the facility. And that's just kind of how it worked. I transferred to outpatient setting with treatment. I'll explain that later, inpatient compared to outpatient. And for 10 years, I was working directly with cannabis use disorder dependent teenagers. Mostly their drug of choice, number one, was marijuana. I dealt with a lot of adolescents that had 2 drugs of choice. And then I've also worked intensely with polysubstance users, which that means 3 drugs of choice. And my story continues in the treatment world with life coaching, primarily transitional adults, in around 19 to 35, and I use 30 to 35 as a transitional adult because I'm moving with the times. So 10 years ago, transitional youth was 16 to 25, and hey, today they've added 35-year-olds in there, and the experience of that is a lot of adolescents after they turn 18 are living with guardians, parents, loved ones, family members. So that's your uncle that's not really your uncle, and they're just not leaving the nest. Some of that is expenses, especially in the state of California. Some of that is on the parents and the guardians and the loved ones. They don't want them to leave. And sometimes it's just, hey, you know, we never even talked about it. So here we are, and now you're 25, and hey, you're still here. Wow. So you ever going to leave? You know? Now, if you're an adolescent that doesn't create any issues, has been an outstanding kid, has never been tardy to high school, parents don't really see you as an issue, right? Except when you're eating all their food and you're not paying any bills and you're on their T-Mobile plan, right? But when you happen to be a substance abuser that tends to create havoc in people's lives, and you tend to be like kind of like a tornado roaring through, that's when I feel that this life coaching part and my experience with parents, which I'll hit on a lot later in my presentation, is the direct communication with parents with their inability to be able to let go gracefully, to be able to detach from that person and say, I love you, but I got to love you from a distance. So I've had a lot of experience with coaching parents and saying it's okay for them to go live at an apartment with 2 more roommates. That means 3 more roommates. And the goal of that is to help them trust themselves and their decisions in order to help the adolescent, young adult begin to trust themselves. Using trust is a big, big deal. I just need to move this little marker. So primarily, my focus today on the first PowerPoint is going to be talking about my experience with cannabis use disorder. And some of my pictures that I'll be utilizing today are very vibrant. They're very intense. And if you live in California, it's a possibility in this field and in the prevention field and education, you've possibly seen marijuana that looks like the picture to the right. In some other states, they've never seen anything like this. And the reason why I've been so compelled to use these pictures is for people to see that not only are cannabis use disorder patients so intense when they talk about their use, their abuse, and proud of that they're dependent, but they know so much about the plant that Joe did an amazing job describing, that look at that picture. And what they do is, and you're going to see many other ones on these slides, and I want you to, while you're listening to the information, I want you to take a look at the picture and be like, that can't be real. This picture and the many other ones, these are not fabricated pictures. These aren't pictures that are, enhanced. This is what the bud looks like with Joe and everything he explained about the farming and the lighting and how they're growing and manufacturing marijuana. It's very overwhelming for not just the user, but the provider like myself when I'm working with people and talking about change, when they're so obsessed with their drug of choice. So cannabis use disorder, and what is it? Okay, so the DSM-5, this comes out of the American Psychiatric Associations and the Diagnostic and Statistical Manual of Mental Health Disorders. So this is the 5th edition. There's been some change, which I'll describe in regards to cannabis use disorder. And with CUD, it's really I'm looking at how often you use and anything that meets the criteria for CUD, okay? So when someone comes into treatment and we meet them, we're actually focusing on where are you today, okay? I know that you're in the room and we're going to do this, this interview, but where are you today in regards to what you're doing with your use? And surprisingly enough, by the time they reach our doors, they tend to open up a lot about what they're currently using, how often they're using, and most importantly, how can you get me out of the jam that I'm in? So sometimes I can really deliver a pitch on what I see in front of me in regards to what the need is. But drug treatment, substance use disorder treatment, has to deal with how we meet the clients where they are. I see a large population that is law enforcement involved. So they've been referred by a judge, and there's an old term called a nudge from a judge, where the judge mandates probation, the officer that's overseeing their case, to attempt to go to treatment, and possibly there they'll find a new way of life. So during this diagnostic process, we're really trying to make sure that we meet them where they are. Okay, we're not forcing treatment on anybody. We're not telling them what they have to do. We're having a welcoming attitude and making sure that they're comfortable. Most importantly, in county-funded drug treatment facilities in the state of California, and I work in the county of San Diego, most of these clients have to be Medi-Cal insured. And in some other states, possibly the one that you live in, they call it Medicare or Medicaid, but Medi-Cal is the state-funded program for people that have that are making under the 200% poverty level. They're referred by probation or self-referred or actually Medi-Cal. But this is how these county-funded programs get paid for, and they have to meet criteria. So I'm going to go through some of the criteria. It has to, at least 2 of these criteria must be met to actually get the diagnosis. But when we're looking at dependents, they have to have 3 to 6. Okay, so there's a series of questions that we ask, but a lot of the times it's the actual person telling their story where we can actually focus on how long they've used, what they've used. And with marijuana and cannabis, they tend to talk about a lot of these things that are listed right here. What I find is number 1 happens to be something that they talk about the most often. So larger amounts over a longer period than that was intended. So here's a question I asked. Before you came to drug treatment, did you ever think that you'd actually be in treatment the first time you ever used? A lot of the times that answer is no. Never thought that I'd end up here or a place like this. And a place like this is sitting in an office like I'm standing in right now. I'm usually dressed the way that I'm dressed. A tie, a jacket, and sometimes if I don't have the jacket on, then you can see the tie and the dress shirt. And I'm doing paperwork with them, and I try and remember that first time I did that group at that group home, right? And how happy I was to be at treatment and making sure that I meet that person where they are. Then we go back to how long have you been using? Now this varies many times, but what I find in the group that I ran yesterday, I had about 4 adolescents in that group. The person that I want to talk about in that group has been using anywhere from 6 to 7 years. So if you've been using 6 to 7 years, you started when you were really young. Now that doesn't necessarily mean that if he's 17 that he's been smoking marijuana all, from 10, 11, he was, doing it 2 to 3 to 10 times a day. What that means is that the very first time he ever was exposed to smoking it himself was around 10 or 11. Now the dawn of his 18th birthday is coming. So I have a really exciting task at hand, is to help him see some truth about his use using this criteria right here and showing it to him, and then seeing if he can have change, right? So that takes a lot of time. And guess what? A lot of the times in these county funded treatment, what we've experienced is that we're limited to time. When I talked about the inpatient facility that I worked for, 21 days is not a long time. 3 weeks to hear somebody's life story, listen to their criteria, meet them where they are, and then strike for a big change. I'm going to say that the surface of the problem would barely be scratched. So really our goal is we're planting seeds in those 3 weeks, and hopefully there's a wraparound service to someone like me, an outpatient, which a referral is made. And then they can continue that for at least 6 months. Now remember, a lot of the times the people that we're working with, they're not mandated to treatment. Joe talked a lot about props that happen in California, and one of them, and I'll just tell you the prop and not the number and the time, the year that it came up, but it really affected substance use treatment because it took the mandate order away from probation. So probation was not mandating treatment anymore. So when I'm sitting in front of somebody and they're talking about cannabis is often taken in larger amounts over a longer period than was intended, that's the very first basis of when you started on this journey of smoking marijuana, you never thought it would be 6 years later. And I'll keep something very simple with all you guys today. Sometimes it's 9 months later, I'm dependent. Remember, dependent is you have 3 to 6 of these criteria, right? So how in 9 months have we gone from you just casually smoking some weed, whether that's vape and what Joe explained, vape, pipe, bong, whatever it is, leafy green oil, to a great deal of time is spent in activities necessary to obtain cannabis, use it, and recover from its effects. Craving or a strong desire to use cannabis, okay? And this is a big one for adolescents, but young adults. Failure to fulfill role obligations at work, school, or home. Okay, and I I continue to look at these things because this is how we help them in the future, meaning the future of their goals. But I say 9 months because the potency that I will be talking about today, it seems like, and Joe covered it a lot. When potency rose, you know, like I said, I was working in drug treatment facilities. In 2005, I was in an outpatient facility, right? I had a key to the door. I was, you know, an assistant manager and then turned into the manager. I have clients coming in every day, Monday through Friday, some sitting in group from 3:30 to 6:30, right? 3:30 to 4:30, I'm doing a group strictly on education. Then they get a little break and then they come in and we sit in a circle for treatment. I didn't see as many dependent adolescents and young adults that I see now. Now remember, a 9-month period, that's short. I'm hearing people, hey, I started smoking 4 months ago and I'm already daily user. Well, what's daily mean? Joe talked about it. You know, those vape pens, they're odorless, they're easy to conceal. And if you're, you know, 15 years old, you're probably like a freshman in high school and you can hide it up your sleeve and, you know, you're going to smoke it. We just came out of one of the most intense times of our lives that struck staying at home, being isolated. You can't go anywhere, but hey, you can go to Target, but you got to wear a mask and, you know, you got to get in and get out. And then they had the essential businesses. So really what I'm getting at is that not just myself, but many others. So if adults were having overwhelming feelings of anxiety, nervousness, then these adolescents were, right? I asked an adolescent, okay, you're locked down, you can't go anywhere except Target or Burger King drive-through, and you got to wear your mask, right? How'd you get, you know, your little stizzy pod that connects to the mechanism? Oh, I hit this guy up on Snapchat, and you had to be invited to his Snapchat, and all he would say is, send me address and Zelle me the money, and he'd show up. So maybe you say you didn't put your address because you don't want them coming to mommy and daddy's house, but he shows up to the Burger King parking lot and there he is. He gives you your little pod, hands it to you. Now here's the question. Some of you on here have full-time jobs, part-time jobs, maybe you're in school. I've done both, you've done both. How does somebody who's 15 years old afford a $55 little canister that hooks up to a mechanism to get high? Daily use, 2 to 6, 2 to 10 times a day. How do you afford that? This kind of goes back to the story of them living with the guardian and mom and dad or the loved one for as long as they are, because marijuana is expensive, okay? And people who start using it, and this is a good researchers show 1 in 6 people who start using the drug before the age of 18 become dependent. This is why Joe pitches that the brain is developing up to 25. It's possible that if you cannot use, you can keep the person from using until then, you know, they got a better chance of not becoming dependent. And there's an old word that we don't use. I try not to use it as often because of its sometimes negative connotation, you know, and that's addiction. When someone hears addict, the first thing they hear is heroin, needles, street dweller. And a street dweller is someone who doesn't have an address, that lives outside. They've also called them bush dwellers. They're homeless. And those drugs, those hardcore drugs that have gotten that title being hardcore, their results usually are jails, institutions, and a lot of people die, unfortunately. That's the truth of our society. But when you relate that to cannabis, nobody's ever going to sit there and say, yep, you're going to be on the streets, you're possibly going to go to prison, and you're going to die. We don't see that, right? So how do we explain that to people who have a tough time explaining it? We move away from the word addiction and we talk about dependence. Now, what I've found is that when you're talking about dependence, a lot of people tend to say, yeah, I relate to that. I got to get you to relate. And in our groups, we got to set the hook. If I can't set the hook, you're going to show up for the next 30 sessions, right? That you have to go to, that you met criteria for, that I'm working with your PO with, or your loved one, your parent. But how much are you going to retain if you've already shut me off? If I'm a know-it-all, you know, kind of a cruise, you know, it's my way or the highway, and this information's right and you're wrong, and I don't have a welcoming and an opening attitude, how much am I going to, you know, really get you to change? And what we find is that you got to meet them where they are, but also too, you have to speak everyday language. So using the word, not you're dependent, but here's what we see when people are dependent, right? If THC, as you know, it's the psychoactive chemical in marijuana, but look at those potency levels. Back in 2003, 5, all the way to 2009, I didn't even see leafy green THC levels at 22, 33%, right? Not physically see it, but mean talking to the adolescents that I was talking to, you know, they were smoking something a little under the 20s. And that's if you had, as Joe knows, you know, the best dealer in San Diego. So you're in 2008, you know, you're 16 years old and you know the best dealer in California and you're going to get the best weed. No, you're probably going to get mid-range. So here's the best top shelf. You're going to get around here, right? Not the worst, but right above it. And you're going to get stoned. You're going to get high. You're going to feel good, right? But you're not going to get the best of the best. Now it's so much readily available. And Joe explained all of this, right? But then this dawn of oils, 60 to 90% THC. And I paused for a second because it's overwhelming in the treatment education field and prevention field. When you have people using that little, I found this image online. That's that little vape pen with that oil in it. Look how small the cartridge is, right? And don't forget, if you know somebody, it's $55. If you go to a dispensary down the street here in San Diego, you're looking at spending $72. And on the back, it's going to have a little fancy package, and it's going to say THC 92%. Some would say that's not, you know, normal levels, right? The potency increase has led to more dependence and confusion for the user. How do I stop once I've started? Now I'm not breaking up the leafy green, which you see on the right-hand side, the intensive pictures that I found, and they get obsessed with these pictures. They're not breaking it up, rolling it in joints, focusing on smoking. How are you going to roll a joint, a bong, a pipe in this office? You're not. How am I going to get to outside this door, go on a break 3 to 4 to 5 times during my shift, my 8-hour shift, to get high? So if you have that little vape pen, some people are probably using in the office, you know, some people are using at schools. At schools in San Diego County, they have vape detectors in the bathroom now. They have kids at these high schools, right, that won't even use the bathroom at school. They want to pass to go home during actual school hours because they're afraid to get stigmatized or accused of smoking vape if I'm standing in the bathroom and I'm a vapor and you're not. So I'm smoking and then that person walks out. This is all true. These are things that I sit with admins and talk about. What are we going to do? And sometimes you say, you got to do your best. And sometimes your best is good enough. Okay. I'm a very positive speaker. I talk about change and I talk about that sometimes you are doing your best. And one thing you're going to hear me talk a lot about today, okay, is communication and listening. Adolescents need somebody to talk to, right? But if you're an administrator and you're doing the best you can on your campus, talk to those people. Why are you hanging out in the bathroom so long? You know, a lot of them, what they're doing, here's their solution, okay? They're locking the bathroom and then there's only certain times that you can use it, right? And then they have somebody standing outside. Why? Because they're smoking so much weed on campuses. That's the truth. This is a great side talking about cannabis risks. And check this out. This is interesting. Cannabis is the most used illegal substance in the U.S. and its use is growing. People that we normally wouldn't see are using cannabis, right? And here's another overwhelming thing. It's still illegal at the federal level, and California has legalized it. But most importantly, although it's legal for adults, okay, it's very, very illegal and harmful for youth, which Joe has alluded to. I've sat in these groups for years, and I've seen teenagers that normally wouldn't have used are actually using. And then here's the part that's interesting, that once they start, they can't stop. So what do you do with that case? This is why treatment is so important for CUD. Outpatient is great, and I think it's a great start. A lot of the times after we do these assessments, this what comes up. The need for a higher level of care. You'll hear me say this twice today, in this PowerPoint and in the one when I talk about mental health, is and how it relates to cannabis. The higher level of care sometimes is shocking to the person or the patient because you have to say to them, you know, I'm really great. It's really great that you came in today. I'm proud of you, and you've answered a lot of these questions. After, you know, this interview, I've deemed that inpatient would be better to start, and then transitioning to outpatient with a lot of wraparound services, possibly therapists, you know, maybe a psychiatrist if we need to get some medication, right? And you see the look on their faces, despair, you know, like inpatient. No. I'm here because I'm trying to get so-and-so off, you know, my back, and my mom and dad stopped giving me money and I'm trying to get that back, and I haven't driven my car in 3 weeks. So inpatient's out of the question. It's just outpatient, right? And what we try and focus on is if we're meeting them where they need to be, then maybe that's where they need to be. Now, what we find is after about 3 weeks in treatment, either their drug test results have not gone down, and I'll use layman's terms as they're not titrating down, so the THC level is staying consistent, or they're higher, and I'll explain that. And then we ask, maybe, just maybe, you need to go somewhere for a 30-day kind of relaxation, right? And they like that rather than inpatient, and it sounds like it's a lockdown facility, and hey, I was just locked down for the whole 2020 and I can't be in there, and all those things. Some of that stuff, if you guys are picking it up, is paranoia, nervousness, anxiety. It's surfacing, right? Because what does the person look like when they stop using? And here's something that's very important to understand. People smoke weed or use cannabis because they like the effects produced by it, right? Although sometimes they can admit it's injurious, right? What I do is injuring myself, my family, my friends. When I drive, it's not very safe, or I've already crashed a car. A lot of times this is not talked about. Driving under the influence, a DUI, driving while under intoxication, not just alcohol. Sometimes it's drug driving, right? And they're getting charges for that. And if you're lucky, you didn't crash into somebody or evade police when you were doing that because you were paranoid, scared, fear, or, you know, as such. But, you know, those things, people don't realize that this is going on in this county of people who are using. Another fact that I want to make clear, you know, that it becomes so dangerous that they struggle to find a way out. And it seems to be that the one favored drug of choice becomes enemy number one. They cannot they cannot stop after they started, and they cannot seem to, what's the word I'm looking for? They can't seem to kind of tell you what the difference from truth or false. I'm going to read this exactly how I wrote it so that I don't miss any of this, because this is the baffling part of substance use disorder, which is a brain disease. Centers in the mind, not the body, right? If you change this word, cannabis, marijuana, weed, for another drug of choice, there's a lot of similarities. The consequences from some other drugs are harsher and come quicker. But I will say this, I had never seen this before until probably 2009 when I heard of tolerance breaks. Okay, tolerance breaks are where somebody uses cannabis for so long that they're not getting the effects produced by the THC anymore, even at high levels, like 90% THC. So they're puffing that stick all day long, right? And they have to take a tolerance break. So now they're going to stop using the oil, right? And probably for what, a week or 2 weeks, and they start smoking marijuana that's less, maybe 20% THC or lower, right? And they kind of take a break. And I said to the first teenager that ever said this, I said, why don't you explain what that means to me and everybody that's in group? And he said, well, he's like, I take a break for 3 weeks on the hard stuff, you know, the high THC. And then when I go back to it, I get high again. And let me tell you, that is addiction 101, although that we try not to use that word anymore. That's dependence 101, where basically you have built a tolerance that's so high that no matter what, your withdrawal, you're willing to walk through that, and it lowers your tolerance so that you can get high again, right? Now I ask this all the time in group. How long are you going to do that before maybe you're going to decide to stop permanently? Because nobody's asking these questions, right? Why would they? These people that are asking those questions, like their parents or their loved ones, they're not drug treatment providers, but I do. I talk about withdrawal management. What are you going to do for the next 2 weeks? Are you going to be able to cope with what's going on? Are you going to move? Maybe you're going to quit your job. Maybe you're going to move out of the apartment you're living with and you're going to go down the street. All of these things are escape tactics. And it's not just cannabis dependence users, it's other users as well, but they definitely do it. There's a lot of similarities with other drugs. But the big factor is that we don't see a rock bottom right? Until the warnings of a doctor, a loved one finally, what they call putting their foot down, or detaching with love, like I mentioned. And that's both these things are consequence based, right? Somebody says, I love you so much, but I got to love you from a distance. That's not a family member. That could be a significant other. And sometimes they walk out, and all the while you're thinking, just for weed. Exactly, just for weed, because people become so engulfed in it, that's all they do. It becomes the daily part of their life. So what's truth about teens that are 12 to 17, not only has it been the primary substance of use, but I have seen some people that hit 17 and then 3 years later come back to see me to say, hey, you know what, I didn't get it at 17, but I'm currently in a drug treatment facility again for my alcoholism or polysubstance use. And now I see what you were talking about, and it's really true that I was a full-blown addiction, and my addiction only got worse. It didn't get better. And I think that's something that's important to talk about in regards to addiction and dependence 101, is that, you know, your best thinking will get you to 12-step programs, to therapy, to jails, institutions, right? So if your best thinking got you there, wouldn't it be possible to possibly take a suggestion where something that's going to change your life would help the person? But sometimes what we have to do is we have to allow them, if they're in a ditch, and I've pitched this before, is that sometimes it's not, we don't want to know how you got in the ditch, we want to know how you're going to get out. And that's really important. We're focusing on, instead of focusing on the problem, we're focusing on your needs and how we can help you get out of that. So adolescents from 12 to 17, there's a lot that goes on. Think about that, 12 years old, you're in 6th grade, right? 17, you're either a junior or you're ending your senior year, or you just started. So if this is the primary substance of choice since 2005, right? How can I help prevent them from long-term use? Really taking all the education that we have that's evidence-based and pitching it in a way where they can understand, and telling them that there's a different way to live. That's really the goal. The number one goal is to meet them where they're at, but really to say, hey, there's a different way of life and you can do something different. This is why I suggest things like abstinence. Sometimes that's all we got, you know. Hey, while you're in this program, 90 days, you know, 4 months, 6 months, why don't you give yourself a chance and actually take a full break, right? And stay abstinent. What we've learned with abstinence is this, is that if somebody is not a dependent person, they can stay abstinent for a long period of time and not touch anything, including alcohol or other drugs. And maybe at some point they go back to it, but they never go back to it like it was. So if they were a daily user, and I'll just focus on daily users. If they were daily users, they go back to doing their drug of choice, I could say, but they never go back to what it was. And they kind of see, you know, it was fun, but maybe I'm not going to do it at all, right? And sometimes they switch drugs of choice, but I don't want to lose my point. But if they are substance dependent, abstinence is only going to help for so long. And what they're doing is they're waiting for the time where they pick up right where they left off. So if you have 6 months of clean time off marijuana, right, and you're just abstinent, it means you don't take care of, you know, your spiritual side, which is going to some kind of therapy or 12-step program. You're not taking care of your physical side, your health, and then your mind, right? So all those three parts. What happens is you're just waiting to pick up right where you left off. And we have people that they call retreads in treatment, and relapse is not a part of the recovery process, but we find that people in general go back to their drug of choice because this time it's going to be better. This time it's going to be different. Watch. This time I'm not going to hang out with those people, places, and things. This time I'm going to use less. I'm going to switch from oil back to the leafy green. Even better, I'm going to just do edibles, and that's all I'm going to do. I'm only going to use in the morning. I'm not going to use at night. I'm going to use it at night, not use it in the morning. I'm never going to smoke at work. All of these things, they're not excuses. This is kind of them scrambling to find a solution because they're trying not to accept the fact that it's possible that they become dependent. Signs and symptoms of somebody who's on the road to dependence, or they are dependent, nervous and paranoid, huge. I mean, I could tell stories that could take us all day of stories that people have told me that are totally fabricated. So they made it up in their mind, or they totally believed it at the time, or they're physically seeing hallucinations. And remember, we're still talking about marijuana, the plant, THC or the oil, right? Slower reaction time, which is what Joe talked about with the actual driving. Short-term memory impairment. Can't find my key. Do you have my key to my door? My door, I can't lock it. Did I leave it in your car? Hey, I lost my debit card again. Hey, my EBT card. EBT is the state-funded program to get people food. So instead of giving them food stamps, they put it on a little card, right? Lost it again. So I can't eat. You know, I have no money for food. I don't get paid until next Friday. Well, wait, I got paid last Friday. And when you're talking about this confusion, or you're saying, what's this guy Pat talking about? This is literally, they can't remember a whole lot of things, right? And then one that's really dangerous, anxiety, riddled with anxiety. How do you leave your house and go to work at Del Taco when you can't even put your pants on because you're so freaked out? And only if you had a little bit of weed to smoke, then guess what? You could get to work, you're gonna kick butt all day long, you're gonna do your honest 8, and you're gonna leave work and you're gonna feel like you're empowered, right? Well, what happens when you don't get paid until next Friday and you have no weed? Remember, that little thing costs $55. Rent's going up here all over the United States, you know, and you got to pay your bills. They're due 3 days ago. So these are things that they look at, the daily users. And then here's a great one: changing friends. People you used to hang out with, things that you used to do. I haven't heard of those people in months. You know, when I life coach people and I sponsor people and I mentor people, I say, hey, what happened to the boxing class? What happened to the jiu-jitsu thing you were a part of? Hey, what happened to the gym that you were going to? What happened to so-and-so? What happened to Joe, the guy you used to train with? You know, I haven't been in the gym in months and I got better things to do, man. You know, and I just don't care anymore, you know? And why would I? You know, I'm here at my house, I'm relaxing, and you know, I've been really into Netflix lately. I pretty much watch Netflix, you know, and that's what I do. And I don't need anybody. When you start hearing these, you know, self-condemning pitches, and you start, you know, really processing with them where they're at, these are prime examples of dependence, right? And if they're sitting in front of you, you have a really great opportunity to say, hey, maybe you can have, you know, a different way of life and try this. There's a lot of things that cause cannabis use disorder. I talked about like 3 months, prolonged daily use for 6 months to a year to 2 to 3 years. But here's the most important part. Every person reacts differently, but there are a lot of similarities. So what works for Joe might not work for me, right? So this is why we have a garden variety of topics and drug treatment, outpatient and inpatient. This is why if I'm the counselor, it's not going to work for you because you don't like my jacket or my tie or my haircut. Maybe Joe's the guy that's going to be there, or maybe not. Maybe it's going to be another staff. But what we try and do is we try and meet them where they are and try and do the best we can. But this is why it's an ever evolving change, right? And how we can help them. Cannabis withdrawal is really important. I did touch on it, but I do want to say psychosis is real, and mental health is what I'm going to talk about later. And they have all of these symptoms for about, it depends on the user, everybody's different, and the potency and how long you've been using. But I'd say that they're going to feel this for anywhere from 7 to 14 days. Tops is going to be about 15 days, so about, you know, half a month. But there is going to be irritability, anger that they can't explain, aggression. Things are going to bother them. My face is going to bother them. And I say that not jokingly, but I've been in group where this guy was just pissed off and he's writing it really rough and he's slamming things down and asking to go to the bathroom 7 times. And I said, hey, buddy, you okay? And he's like, no, I really don't want to be here today. You know, you really annoy me. Hey, I don't take those things personally. I've been called every name that you can think about, inpatient treatment and every name in outpatient treatment. And these life coaching gigs that I have with clients that I work with on one-on-one, I've heard everything. Because if you're dealing with the nervousness that they're dealing with and the anxiety levels that they're dealing with and irritability, and then, hey, you got to be in work in 3 hours and you haven't even taken a shower, yeah, I'm the last guy you want to see. And when I'm talking about positive change, okay? So dependence, I want to cover one thing on this slide, and I'm going to jump to the next. It seems that they need, with greater concentrations of THC, it's leading to dependence earlier. But also, here's the main part, marijuana over time, they need to experience those higher concentrations to actually experience the high. And then what happens when marijuana stops working and they don't want to take tolerance breaks, they don't want to stay abstinent, and most importantly, they want to get high and use for effect. I will not go too far down that rabbit hole, but I will say this, that they tend to start using other drugs in connections with marijuana. So it's not just going to be marijuana, it's going to be marijuana and. So it's possible that maybe it's going to take a little cocktail of 3 things. I'm going to smoke a little weed, I'm going to drink 2 40s, which is about 6 beers, and then I don't have work today, so I'm going to take half an Ambien and I'm going to sleep for a couple hours. Now, if you're on this call and you're hearing that, let me tell you, don't ever take those 3 in connections. That's bad. Have I heard that? Yes. Are you thinking people really do that? Yes, they do. Now, it's possible that person might not wake up. So you're using a downer, 2 downers, actually 3 downers all at once, but maybe that's just what they need in order to feel okay in their skin. And what I find out is a lot of times they're struggling with the left and right side of their brain. I mean, what's going on up here? You know, not being able to trust themselves, you know, doubt. Why am I here in my life? And if I've ever worked with somebody right before their 30th birthday, oh man, they have a tower of things that they're staring at, like a tidal wave coming down on them. And if you think, if I think that anything I'm going to say in a 3-month period is going to get them to change, like I said, I'm barely scratching the surface of the problem. So that's why sometimes it takes 6 months to a year, maybe even 2 years, 24 months to really say, now I really know this person and here's what they need to do. We covered this. This was huge. Risk factors, adolescence, the brain is still developing, exposure to substances at a young age. And a lot of these kids, there's 2 of them that are holding cell phones in their hands. We cannot prevent, Joe and I talk about this all the time. Him and I had a mini discussion about this literally the other day. You know, probably for 10 minutes we were talking about the phone. You know, I have a daughter, and when is it a good time to give my daughter a cell phone? She has a tablet already. Uncle Sean bought one for her for her birthday. That's great, right? Now she says, tabby, tabby, tabby. She's 2 years old. She doesn't know how to turn it on, but she knows how to get on, touch the YouTube button, you know, and I don't want to prevent her from technology, but there are a lot of safety factors that I'm concerned about. 20 years in the field, I know what adolescents do. Hearing stories about, I was 10 years old and I'm hanging out with my Uncle Bob and we smoked a J on Christmas Day. What? That's crazy. Uncle Bob, what are you doing, right? Kid's 10 years old going on 11, but those are real stories, right? We talked about substance use disorder, but with that 10, you know, person who smoked first at 10, remember, we're looking for symptoms. Sometimes they're going to be mild. That's why when I create and I look at these PowerPoints, we're talking about people meeting them where they are. So sometimes this is where they're going to be. Hey, I've only smoked for the last 4 months. And I put the pedal to the metal when I saw the cop in my rear view, and now I have a DUI, and here I am. So what can you do for me? You know, I guess I'm punching a ticket. Do I really have to come for the full 3 months? Like, is this group really an hour? Okay, anyway, those are the attitudes I get because that person probably is not a dependent, but they're sitting in group with people who have a severe issue, right? 6 or more symptoms of the thing that I described, the criteria, right? Now, question. Do these people belong in the same group? Yes, and I'll tell you why. Outpatient setting, it's very safe because they're not teaching each other what they're doing. We're all kind of engaging with the topic that's on the board, right? Once again, I'm simply stating what I believe to be true based off the evidence-based curriculum. And there's 2 things. The person who is an intense user, they're looking at the person that has a mild symptom and they're saying to themselves, you know, I remember when I used to use like that. Can I get back to where I was back then? Not necessarily with using, but the things that I have. Because what I find with people who have substance use disorder, addiction, dependence, you start to lose things. You all of a sudden aren't taking a car ride anymore, meaning your car, you're taking the bus. Can't afford Uber because that's too expensive. I don't know who takes Uber anywhere anyway, but you know, you start taking the bus or you start walking places, right? And what I find is when you start losing things, they might fib to you a little bit. They might bend the truth, but it bothers them. It's bothersome when they see others succeeding, especially siblings succeeding, and wondering, man, we're not too far apart in age. How did he get there? How did she get there? And I seem to be stuck, right? I use this often, and Joe really likes when I use this pitch, okay? And I got to tell you, because it's very simple. People are stuck sometime in a time bubble. And I've met people in treatment right in front of me 6 months in, and I'm saying to myself, okay, you're 23 and you're stuck in, let's see, 6 years ago. And a lot of the times this road to recovery is they're stuck or frozen in some kind of traumatic event that happened to them. And for whatever reason, they can't get out of it. But here's the thing, everything that was going on at that time that was good, they seem to hone in on, right? What was it? Was it junior year, senior year? Was it the soccer crew that you were in? Was it the Letterman's jacket? What was it for you? And what I find is, and I'm talking about a client that I actually worked with, these aren't things I'm making up. And what happened to this person is that he really cast his own shadow on recovery because for whatever reason, he couldn't deal with the past. He could never let it go. And he tended to be frozen in the moment with it because he was broken, right? He went to psychiatrists, therapy, and he saw me professionally for his substance use disorder. And what tended to happen is anytime there was good in his life, and I'm explaining this as simple as I can because I really want you guys to understand this. He always tended to pull in the worst. It could be the best day in the world for him, right? And he'd pull in the worst and say, yeah, you know, it'd be a lot better if that situation hadn't happened to me. And let me tell you about that situation. And he goes down the detailed list of everything that happens, almost like we're reliving it together. Because here's the pitch, you guys. What does it look like if they change? What does it look like if you're actually successful? What does it look like if you don't have law enforcement involvement? You're not going to another court date. What does it look like when you don't have to call Uncle Pat and say, hey, I'm in a jam. Can I borrow $3,000 for a criminal lawyer because I blew it this time, you know? So what does success look like for somebody who has experienced not a whole lot, right? It's tough to see because then you have to really lay the past to rest. And this is something that's important. And it's something that we, myself as a treatment provider, as a life coach, as a mentor, I say, the past doesn't exist, right? It doesn't exist anymore. The future isn't here. What you have is today. And if I can get them in this 8-8-8, so in a 24-hour period, we split it into 3 different sections at 8 hours at a time. 8 hours for sleep, 8 hours for work, and 8 hours for play. This is why it's so important to get them into healthy activities. Having a job is a healthy activity. It helps them succeed. Putting goals on a piece of paper. And this helps them not get stuck in, I don't have a job, I'm just sitting at my house and I'm thinking. Somebody who is a substance abuser, dependent, being alone by themselves, being a recluse, stuck to their own devices, it's a very dangerous. Isolation is very dangerous for them. I covered this already, client eligibility for treatment, but I think it's really important to cover the first one, self. I meet a lot of people who know that whatever it is that they're doing and participating in, it's not working anymore, and this is why they come to the doors of treatment. So they're coming for themselves, and it's very, it's an honor and a privilege to work with all the peoples that are on the referral list, but really to work with people who are coming because they're saying, I just can't do it anymore. It's kind of like a way of surrender. A lot of county funded treatment facilities, like I talked about, we're utilizing Medi-Cal as the funding source. For other treatment facilities paid for, I guess the question could be asked, what's the difference between the two? I think it's the eye of the beholder, outpatient treatment facilities, the ones that I've worked in for decades, 2 decades, amazing treatment that's provided, inpatient, we have intensive inpatient services, which is 3 to 7 times a week. And we have outpatient services, which could be 1 time a week for 30 minutes. We check in. But, I would say it's the eye of the beholder. I've worked in those private sectors and they have great services. But it depends on the person, I guess I could say. Now, here's the thing. I talked about the treatment group, but I don't want to ever forget, that individual counseling, that one-on-one, and then wrapping in the family is so important, right? So we actually get to meet the person. We have the criteria. All of these things are really important for them. We schedule them in a treatment group, and then we do individual counseling. So we're doing one-on-ones to really focus on how we can meet them where they need to be, as I've said. And then we try and see if we can get family involved. Treatment it can be a family affair, and if you want your family there and transitioning and us to help you describe and help them to see where you've been and what you've been doing is important, because sometimes they need that bridge to mom and dad or loved ones or whoever it is that they're talking to. And sometimes they don't know how to say, hey, I've been gone for 4 years and I haven't really been in contact with you, and here I am and this is what I am. And a lot of times those conversation goes, you know, I'm a full-blown alcoholic and I've been in outpatient treatment, and this guy Pat's going to help me deliver more of the message. And a lot of tears come, and that's when healing starts. And sometimes family doesn't come around. They don't want to be involved, and that's okay. Our education workshops are phenomenal. They're amazing, very structured, very informative, and it's stuff that literally is so simplistic, and the nature is so that people can pick it up. And what I think is great about the participants in the group is a lot of the times they're sponges and they're not resistant. They want to change, you know? And I will say this, but there's a lot in there. Half of the group depends on the group. Some people don't want to be there, which I've explained and talked about some of these people already. Social activities are important. These are, let's go to, in San Diego, we have Balboa Park. If you're ever here, please come and visit. And we have the Balboa Park Scare Trails. And we went to haunted trails and took 9 teenagers there, and we're standing in line. It's pitch dark. There's no lights out. The boogie monsters are everywhere. And here was the goal. The next week in group, when they least expected it, I said, okay, so you went to a social activity. So how was it being there and you weren't stone drunk or such? And this is the feedback that I got, and I want to share with you guys. They say, you know, that was the first time that I've done something fun in 6 years where I didn't have to be drunk, blacked out, couldn't remember it, or be stoned the whole time. I was like, wow. And another guy said, I remembered the whole thing, and I haven't laughed that hard in such a long time. What we're really trying to do is get them back where they were before they started using. That little boy, that little girl, say, you know, you started using, you know, you're 27 now. When did you start using? When I was 12. Okay, well, how is life from 1 to 12? How do we get you back to where you were, you know? And some would say that some of them have the mentality of a 12-year-old. That time bubble, time warp I talked about, sometimes, you know, their behaviors are like that, you know? Sometimes people have said, experts have said that when people start using, it stunts their growth mentally, physically, emotionally. So sometimes when we meet people in treatment, they're 27 years old, but you know, there's a 12-year-old in there, you know? And what I found is when they start working on themselves, that happens really fast. They grow up quick, you know, and they learn quick. But everything's a process. You're not going to take somebody who's done 12 to 15 years of hardcore drug use or alcohol abuse, and they're going to be rendered white as snow overnight. It doesn't happen. It's just not, it's not science. So client engagement, we're using, you know, these tactics, motivational interviewing. That's what I've been trying to do this morning. And so when we get to the slide, I can say we're using words that are non-abrasive, abusive, or labeling, you know, and saying, instead of someone, you know, you're an addict, you're a junkie, you're a tweaker, you know, you're a stoner. We don't use those words, because remember, we're trying to get them to come back. How are you going to come back if every time I'm calling you a stoner and a dope? You know, they're not going to respect that. They respect you saying, hey, Pat, it's good to see you. How you doing today? You know, I'm not doing all right. Leave me alone. Right? Hey, well, I'll be here later. Hey, Joe, how are you? And I get that, you know, that fire back. But how about on the days they're doing really well and they say, hey, I landed that job at Del Taco, or I landed that job at Denny's, and they got me part-time washing dishes, and you see, you know, that smile on their face. Amazing. It really is. I do include parents and guardians and treatment goals, and sometimes these people don't exist with adults, right? So sometimes we include their loved ones. It's usually their significant other or the person that they're living with. And as I've talked about a couple times today, starting the trust building process, right? Takes a long time. You can't wind something up for 10 years and then unwind it in 3 months. It doesn't happen. So if you've been lying, cheating, stealing with your parents for years, or your wife, your husband, or your you know, your significant other, your partner, don't think that they're just going to say, yeah, man, you got, you know, 4 months. I really trust you to go out on a Friday night to that meeting. So like it says, everything takes time. Parent support is important. Family therapy, case management, talking about current trends so that they know how to meet them where they need to be. In treatment, we're helping them get where they need to be. but parents know you better than anybody. So it's really, really helpful when parents are a part of. But I will share a story with you. I knew a guy, and I hope this doesn't blow your mind too much, because the day it did me, I kind of choked up a little bit. Today I'm not going to, because, but I hope you don't, okay? I knew a guy who was clean and sober 28 years, 28 consecutive years sober. That's one day at a time without a drink, drug, or pill or powdered form. And I said to him, I said, hey man, so when you made amends to your parents, how was that? He said, oh, I had a different experience than most people did. I said, well, tell me more. He said, they accepted my apology and they said, son, we love you. Good luck to you in life. Don't ever come back to our house. So I stopped for a second. I said, okay, well, yeah, that's great, man. So that was what, 87? That's nice. And he goes, oh, my friend, he's like, I still don't talk to my parents. He caused so much wreckage that his parents said, the last time we saw you in 87, right, you were on the news, embarrassed our family. So sometimes this parent support's not going to be there. And the reason why I welted up that day was because here's a guy, 28 years of consecutive clean, sober time. Life is phenomenal. You name it, the guy's done it, you know? And his parents still are like this. Thank you. Right there. That's good. And here's the thing. It's because for 15 years, he was a tornado in their life and he caused so many issues. Some stuff can't be repaired. And I say that as truth because he didn't have to build trust with his parents. Here's the thing he did. He built trust with his children and he continued to live his life. All these things are great if parents are supporting, and sometimes they've seen enough. So in our field, I've seen both, and it's a cold hard truth, you know. The Access and Crisis line. This is in San Diego. Health and Wellness. There's a 211 line here. I hope that in the state of Illinois that it's a simple Google search for you. If not, you're on this call and you can't find that number. Joe and myself will help you find it in the state of Illinois. And it's good to have this. 211 is great. I can call 211 and say, hey, you know, I'm looking for support for this EBT card. Can you help me? So it's not always psychiatry or support groups or 12-step programs or you're in a crisis. It's really like you just need some services with help, right? Barriers to treatment. I covered the no rock bottom. Cannabis isn't a hardcore drug. It's so tough. I have a biased opinion because I've been doing treatment for 20 years. So when I say things to you guys, cannabis, heroin, and meth, they're not on the same plane, but for me, I view them as drugs of choice, right? So the difference between those three, without going too far down, is this. If you're using methamphetamine and you're using heroin, what we find is that you're probably going to end up in some kind of institution faster than somebody that did cannabis, or if you're going to end up in some kind of lockdown facility, either prison or jail. And that's just because it seems that people that do those drugs end up losing everything faster than somebody that did cannabis. And I've met people who are lifetime methamphetamine heroin addicts that haven't lost it all and might not ever, you know. But it seems to be that the more hardcore drugs, they do find themselves in situations that are sticky and you can't get out of it with, just a simple, I'm sorry. So that's a barrier, not for us, but for the person that needs help, right? Marijuana isn't addictive. I can quit whenever I want to. If Joe and I told you how many times I've heard that since 2003, probably in the first year of me running treatment groups, I heard that more than a handful of times. Hey man, let me just stop you there. I'm here because my PO wants me to be here, and if I wasn't here, I could stop whenever I want, but I don't want to stop. So I'll be stopping for 4 months, 121 days. When I'm done with you and all the other crap I got to do, the day I get out, my friends have already planned a party for me. So, okay, have a good day. That's their check-in. You're like this, okay, great, thanks for sharing, and you got to move right along. What am I getting to? Another barrier to them is their inability to not being able to have change because they want to argue their point. The biggest goal in treatment is not to argue. You know, they are experts at what they do. You're experts at what you do. So when we use this motivational interviewing tactic, it's really saying, hey, wow, I'm really glad you shared that. And you participated really well today. Thank you. And you move on, right? And here's I feel compelled to say this. A lot of times the people that come to treatment, they've been kicked out of every place they've ever gone to, and they've been in principal's office, and they've had their parents come. Every teacher's had something bad to say about them. So the worst thing that we could do as treatment providers is kick them out of a group. I can't tell you the last time I kicked somebody out of a treatment group. If you get kicked out of my group, you've done something, terrible, right? But I say to them very simply, hey, I want you to stay, but if you stay, you got to participate in this way. Thank you. And most of the time, they do. Two things about lack. They lack the motivation to want to change because of their drug of choice. Marijuana pulls motivation right out of them. They have none, like empty. And lack an interest in treatment. Why? A lot of the times it's self-help, it's work, it's something you have to do. When they say you got to walk through the steps or take the steps, the actions in the feet, you actually have to do the motion, right? Got to hit on curriculum, evidence-based curriculum. It's really focusing on your thinking, right? Communication with others. How are your peer relationships? Self-control. And then the last one, relapse prevention, right? How do I prevent myself from going back to the friends, people, and places that I went to? What do I do? And if you don't give them, if they have 10 things that they normally do, you got to give them 10 things that, outsource that. And here's one right here. You ready? One of these is coming up, and it's really overwhelming. Sunday's what? Halloween, right? And then guess what? 25 days later, you gotta go sit with your family members after you've been running and gunning the streets for the last 3 years, and sit down with mom and dad and Uncle Terry, and Bob's coming down from Sacramento. And what do? Everybody's happy and has a smile on your face, and you're trying to cope with, I don't want to sit at this table, so it's overwhelming. What are you gonna do? Sit at the table and tell everybody, hey, I'm in drug treatment and I'm an alcoholic? It's not easy to do, right? That tidal wave of anxiety. And then I still have my two fingers up. Here's the third one. Then Christmas comes and the other holidays. Okay, so that's a lot for somebody. So what we try and do is before those dates, we try and say, make a plan. And here's a good one. On Halloween, maybe it's good. Maybe this year, I've said this to so many people, and let me say this. Personally, I've taken this advice when I was newly sober, okay? Maybe this year, Halloween, you just go to a 12-step meeting and make sure you hang out with somebody in recovery, and you just don't go and get dressed up and go out to a party. Maybe next year. That means, ladies and gentlemen, that you have 364 more days until the next Halloween. And in between this one and this one, this holiday to this holiday, maybe there's going to be some growth and you'll be okay. But as of today, it's probably better you just don't go. Because when in doubt, probably should go to therapy, one-on-one session, maybe go talk to obviously your counselor, or go to a meeting. I mean, those things are important, because nothing's worse than making somebody who's, substance dependent do something that they don't want to do or they're not ready for. And I've had people say, I cannot go to Thanksgiving this year. There's no way I'm going to fly back home. I'm just too overwhelmed. And I've had to say, you know what? Then if that's your gut, follow your gut, right? Because what might happen if you push them to do something they're not ready to do, could be disaster. And then that trust building process goes out the door, because you told them to go back and everything was going to be okay, So goals, here's what clients learn. They learn to be responsible for their own recovery and help build a support network that they're responsible. What we tell them all the time, start letting the past go. You're not responsible for your using. Yes, you take ownership for it, but it's in the past, but you are responsible for change. So you're going to have to start today, right? Connect with the community that they live in for social activities that are positive and that are healthy. Make sure that you have at least 10 phone numbers in your phone. And if Joe's not answering, you better call Pat. And if Pat's not answering, you better call the third person and call, excuse me, all the way till you get to somebody that answers. And if you can't, then that's when you need to go and actually physically show up somewhere and attend a meeting, a therapy session, or whatever it is. And try and master the refusal skill. Now, this is something that's practiced. Sometimes it's okay to say, hey, I'm in treatment, I get drug tested, I can't drink or smoke. Then I ask the person, where were you when you said that? Well, I was at a baseball game. Somebody had tickets for the Padres and they were playing the Dodgers and I had to go. Great, always have an out. Have your own car, have those 10 phone numbers, and when in doubt, if you feel nervous, say, hey, you know what, man, I had, thanks for the hot dog and the licorice. It's inning 5 and I gotta go, man. I gotta wake up really early. And somebody's gonna say, oh, no problem. Yeah, man, you got it. And if someone challenges you, the best thing to do is bow out gracefully. Yeah, man, I gotta wake up really early. Man, 5 innings of baseball, tummy's full, I gotta go. What's really going on is I think that person is getting nervous, like, hey, how do I sit in a social situation at the Padre Dodger game with my best friend who's drinking a beer and he's been smoking his vape pen the whole time? That's nerve-wracking for someone who's never done that. First time sober ever doing that, you want to have a plan and talk about it with people, you know? And remember, if you tell somebody your plan, it'd be amazing how somebody who's a mentor, life coach, sponsor says, wow, that's a plan, yeah, but here's some suggestions, right? And I've said this to coworkers, and me and Joe have talked about this, even on we vacation together. He's been a part of my family for a long time. People have a really hard time taking a suggestion. Prison is filled with people who couldn't take suggestions. And I've said that to people who I love dearly. Hey man, will you just stop being so stubborn and take a suggestion? Just one, you know, and maybe it'll work out for you. I'm good on time, but this is an important part. And I got about, let's see, 4 slides that talk about urine testing. So what we do, the matrix that we use is it's the most widely used drug testing method in the United States. Urine is quick, closing of the bag, everything is good. I've been doing it since 2003, right? We don't do hair, we don't do blood, we do saliva testing, but I didn't have a slide for that. The detection window is very small for saliva. So like, give me an example since I just jumped right into that. The detection for marijuana, as you'll see, is higher. Anything that has to do with saliva is cut in half. And for instance, if you're a methamphetamine smoker, urine, it's up to 3 days. Oral testing, if you used yesterday and I test you after 12 today, it's possible to come up negative, right? So we usually utilize urine. Here is the length of detection for marijuana. So moderate users. So these aren't these are people that are on that DSM-5 that I showed you guys. Use mild or moderate. You know, these are 4 times a week. You're looking at the detection window is going to be about 5 to 7 days, right? Okay. Chronic users. This number changed about 5 or 6 years ago with the potency rise. Now it's 10 to 30 days or greater, right? So 9 weeks later, somebody's still testing positive for marijuana. That does not mean that they're continuing to use. What this means is the potency is so strong that it's still coming up or it's still titrating down, right? So these are for people who smoke daily and they've been doing it for a long time and they've been using these heavy concentrates. I won't talk about the other drugs of choice that are on there, but just marijuana, you can kind of just get a taste of how we're doing things. This is why the window of drug testing is every 7 to 10 days. So usually for outpatient drug treatment facilities, we're testing about twice a month. Some would say, why is that? Because we're trying to build that trust, remember? So every time you're coming to a group, I'm like, hey, I'm gonna test you. Then I start taking another role, like I'm law enforcement or probation. You know, I'll let them do their job. That's their job, catching people, you know? That's not my job. 2011, I saw positive results at this level, about 200 to about 1,500. And then around 20, I'm sorry, this is modern day, 2021. And this has been like this ever since the concentrates went up. The positive test range has shot through the roof. I mean, the first time I saw a positive test for 14,000, I think I called Joe and I said, you have to see this drug test. And he's like, oh my God, that's insane, you know? And it just means, man, you're smoking some really good stuff. And yeah, and it's gonna take longer for it to get out of your system. This is an actual positive test. So this was collected September the 2nd of this year. I want to tell you something funny about this because I'm on it. It was reported on 9/20. So you see the dates are about 18 days in between. It's because this person that actually, this company that actually does these drug tests, during the pandemic, they had a lot of people working from home. When they asked them to come back, nobody wanted to work in the office. They wanted to do everything from home. And thank you. So the urine test for THC is 7,400, right? And like I said, this is something I didn't see before, but I wanted you guys to see. I could have found one that was like 15,000 or 18,000, but I thought this is an average, you know? And I don't know who this person is. This is something I just grabbed off the actual, you know, a logged in website that I'm a part of. But this is actually a client. And I wanted you to kind of see how we read them. So there it is, the 10 panel test. You can see the 10 things we test for. And then it says it's positive, and there's a confirmation test for THC. Hopefully this person, if you see the THC creatinine ratio, it says outcome, go to the past the middle under positive, it says 35.19. That number is important. That's the number that we can tell the potency of the marijuana, the quality of it. And that means that 35.19, this person smokes or uses really good THC. Some pitfalls for people when they're in treatment. Really simple. People, places, and things. The people they hung out with, the places they did that at, and then the things that they do, we have to help them change these three things, right? And we always say this, it's gonna sound kind of intense, kind of black and white. What I find in treatment is that if you are more black and white with things, not hard lined, but really with suggestions, it really helps to say, you only have to change one thing, and that's everything, right? I've heard this many times, and I pitched it many times in group. If nothing changes, nothing changes. If you always did what you always did, you're always gonna get what you always got. Your best thinking got you here. So let's try something different. Here's a suggestion. Stop hanging out with the people, places, and the things that you did for a year. And if you can't do a year, do it every day that you're in this program, right? Try and make a new friend. At least get a person or somebody you can hang out with for the next 90 days. And if you have to do it in group, if it's a to-do list, why don't you do the to-do list with somebody else who has a to-do list? And what you got to see is, hey man, for the first 90 days, we just did it. We didn't use, we didn't drink, we didn't hurt anybody, and we were okay. And don't go to those places that make you nervous. If you get that gut feeling like, oh my God, I can't go there, then don't do it, you know? Or what I find is this, if you hang out in barbershops long enough, you're probably gonna get a haircut. And first time I ever heard that, I want you to see my expression. I was sitting in group and I was like this, what is this guy talking about, you know? I've been sober since October 25th, 1999. I haven't had a drink, drug, pill, or powdered form since that date. And that's from a 12-step program and a lot of spiritual work, okay? And the reason why I say that is it can be done. So today I'm 30, I'm gonna make sure I get this right, I'm 37, and I have 22 years sober. So I got sober when I was 16. So when I went to treatment, they said these things, you know, if you go to kickbacks parties where people are boozing and drinking and living the fast life, guess what's gonna happen? Eventually, even if you don't want to, you're gonna end up with a beer in your hand. And I believe those guys, you know, and if you do the things they do, you're going to get what you always got. And for me, when I got to treatment at 16, I'm sure you guys have realized this in like the last, 10 seconds, I wasn't winning at life, right? I wasn't doing all the things that I needed to do. That's why my parents helped me kind of get that in there. You know, I was already involved with law enforcement, and these things really helped me. But I made that facial expression because when that guy said that, I'm like, this guy is so out of his mind. I got to get out of here really fast. And in my future, I thought I'm going to party really hard and I'm going to do whatever I want. And there was another plan for me, and here I am today. Self-help programs. Actually pulled Narcotics Anonymous and the ChicagoNA.org. I found this on there. So this is Narcotics Anonymous in the Chicago area. This is their actual number, and that's their website. Chicago Alcoholics Anonymous, Area 19. If you search this in Google search, and if you're on this call or you know somebody that needs help, both of these facilities have anonymous meetings. Closed meetings are strictly for people who are drug addicts for NA, and alcoholics only. So if you're unclear or unsure, you want to go to an open meeting. And here's the cool part. You just go to a speaker meeting. Here's another tip. Go to a speaker meeting and just listen to them talk. And if you have a loved one, maybe tell them you're going and see if they want to go. But my next slide is really important. Does self-help work? I think this is my last slide. No, yeah, this is my last slide. Does self-help work? Self-help programs, they're designed to enable the person to become free from all mind-altering chemicals, right? Including marijuana, right? Is alcohol a drug? Yes, it is, period, after that statement, right? So they enable the person to get free from that. 12-step programs have a set of principles, very simple in nature, that are to be taken from 1 to 12. And here's most importantly, that if you attend them and you do what they say, change happens, right? But this is a suggestion program. That's why I put that as the next little bullet point. 1 day at a time, easy does it, just for today. So do they work? They do work for the person who attends and actually works all 12 steps, right? I get this all the time. You know, this guy I worked with, he had like, meaning he was my client, he was probably in his late 20s. And I said, have you ever been to 12-step? Yeah, I've been to 12-step. I've been to like 10 different treatment facilities. 12-steps doesn't work. All those people there are loser idiots that just hang out at meetings. And I said, okay, I have a couple questions. And he goes, okay, go. I said, have you ever gotten a sponsor, a mentor in the program, and have you worked the steps from 1 to 12 as it's outlined in the book? And his answer was this: well, no, why would I do that? I went there because I was forced to go there. So obviously his first point might have been false, or it was a little bending the truth that it doesn't work and everybody that goes are losers, right? And he made a great point. So I want to kind of pitch this. I've been to 10 treatment episodes since I was 17, and now I'm 28, and here I am in a treatment episode, and somehow you were hired. Here I am, right? So if nothing changes, nothing changes. Last but not least, aftercare. Weekly check-in groups, wraparound services, and this integration back to normal living. I love the word normal. People like to say, what's normal? Who's normal? There's a lot of normal things going on in the world and in the United States. And if you're a drug user and an alcoholic, you've kind of taken a break from society while you're in your addiction or your disease or whatever you want to call it. But man, there's a lot of normal stuff going on. And when you get back into that normal living, that's when people start saying, hey, it's okay to go back to mom and dad's house sober and clean on those holidays, and do your best, right? I am going to look for questions because the next part of this PowerPoint is the one I'm doing after Joe goes again. So if there are any questions, let me see. Got to raise my little box up here. I'll ask Orlando if there's anybody. Okay.
As of right now, there's no questions.
Okay, Orlando. Yeah, I'm just going to switch Joe back over to his PowerPoint.
Yep. Escape.
Okay.
Mine. And then Isaac. All right.
I'm going to put this back there.
Wow, that was really something. I got to tell you, you're not going to find somebody with an extensive background in substance use treatment working specifically with adolescents. But I do want to show a video. This is a 20-minute video. I think it's very important because you've heard from treatment, you've heard from prevention, and now I want you to hear from doctors. This was a news event that we recently put on in May to introduce this new Isaac group. There's something about this news event that was really powerful, hearing from doctors who are not political. They're just trying to advocate for smart public health approaches when it comes to marijuana policy. So I want to play this video. You can disregard the beginning a little bit. It was housekeeping items. It was my first time. Let me get the full view. It was my first time hosting an event like this, which was, a little intimidating, doing it completely on Zoom and inviting the media. But here we go. This was May 9th, 2021. Welcome to the Isaac News Conference. We're very happy to have you all here today. Before getting started, I want to cover some housekeeping items. My name is Joe Everstein, and I am with the San Diego County Marijuana Prevention Initiative and the Center for Community Research. All attendees' microphones and videos are off. You will only be seeing our speakers. Chat has been disabled. We have numerous people registered for today's news event, and in the interest of time, we are going to prioritize questions from news outlets. We are going to address questions at the end of the event. There are two ways you can submit questions. You can enter them into the Q&A box or raise your hand and we will unmute you. Please state your name and the media organization you are representing when submitting questions. Lastly, today's event is being recorded and will be available by the end of the day. You can access the recording by going to our website. A link will be provided in the chat. We will additionally send a link of the recording to all registrants. Again, I want to thank you, and I would like to pass it off to Dr. Renee Lev.
Welcome, and thank you for attending today. We're very grateful that there is much national and international attention on this event. My name is Dr. Ronit Lev. I am an emergency and addiction physician at Scripps Mercy Hospital in San Diego and Vice President of ISAC, the International Academy on the Science and Impact of Cannabis. Every shift in the emergency department, I treat cases of marijuana poisoning, every shift. And today we are proud to unveil a new and unique medical organization, ISAC, which stands for the International Academy on the Science and Impact of Cannabis. We are doctors educating on marijuana. You will be introduced to the 4 physician founders of ISAC who will explain the mission and resources of this physician-led organization. I will now pass to Dr. Eric Voth, President of ISAC.
Good afternoon. I'm happy to be with you. Appreciate you being with us. I'm Dr. Eric Voth, and I am the president of ISAC. I practiced internal medicine, pain, and addiction medicine for 36 years, as well as my involvement with the issues around marijuana and drug policy that really dates back at least 40 years. And during that time, we've seen marijuana become a serious public health problem. Today, as a direct result of rigorous efforts to legalize and normalize marijuana, it is responsible for a host of medical problems that you will have an opportunity to hear more about from our leadership today. We face not only greater availability of marijuana to younger populations, but also the industrial development, more concentrated, dangerous, and more addictive forms of marijuana/cannabis. This also impacts other chemical addictions. An example would be the dramatic increase that we've seen with opiate overdoses as marijuana has become more widely available, accepted, and stronger during these legalization, medical marijuana, and normalization kinds of episodes. We also face an uphill battle to make the public aware of the medical harms of marijuana, and we face a well-financed, aggressive marijuana industry that profits from marijuana abuse and addiction. As an example, past month marijuana use in ages 12, or in those over age 12 and older in Colorado, where the drug is legalized, that initially was just medical access, is now 17% versus 9.8% in the rest of the United States. From 2002 to 2019, the number of people over age 26 with marijuana use disorder almost doubled from 1.4 to 2.2 million cases. Adolescents with a past year of major depressive episodes were more likely to be marijuana users than those without a major depressive episode. And that would be 25% of that group versus 11% of those that don't. ISAC was founded to fill a serious void of knowledge on the medical, societal, and social consequences of marijuana use, as well as to educate physicians, policymakers, and the public on these really significant impacts. The medical experts on the ISAC Medical Advisory Board bring a whole range internationally of expertise on marijuana together from a broad representation of medical fields. Unlike any other organization, ISAC literally consists of doctors educating doctors on marijuana. ISAC will use medical evidence and science to shed light on the dark realities surrounding marijuana legalization and medicalization. Our mission statement is straightforward. ISAC counters the pervasive misperception of the safety of marijuana by the involvement of international experts who provide science, data, and clinical expertise. We are a nonpartisan, non-political group developed, organized, and guided by doctors. We intend for science to guide policies that protect the public and create informed decision-making. Thank you, and I will now pass the floor to Dr. Ken Finn, Vice President of ISAC.
Thank you, Eric. My name is Ken Finn. I'm a pain medicine physician in Colorado Springs, another vice president of ISAC. I am also the editor of the only medical grade resource for those interested on this topic from the United States, Cannabis in Medicine, an Evidence-Based Approach. There's a lot of literature on marijuana, and as an example, the Surgeon General Advisory on Tobacco was based on 7,000 publications. Between 2011 and 2019 alone, there have been more than 15,000 marijuana manuscripts, which indicates a 140% increase in the scientific literature, with publications being added on a regular basis. Colorado has had medical marijuana since 2001, and nearly 90% of recommendations for marijuana are for pain. Despite that, 2020 shattered another record in drug overdoses. And since legalization, drug-related overdose deaths have skyrocketed. Since legalization in Colorado, prescription opioid deaths have increased by 136%. Fentanyl overdose deaths have increased by 864%. Methamphetamine overdoses have increased by 364%. Cocaine deaths have increased by 195%, and heroin deaths have increased by 45%. One of the platforms to legalize is to help our opioid epidemic. Marijuana is not helping the opioid epidemic and is likely fueling it. Similar data is being seen nationally and in other states. For instance, California has had medical marijuana since 1996, yet their drug overdose deaths and overdose presentations to the emergency department continue to be a problem. Although there is evidence of potential benefit of cannabinoids in certain medical conditions, dispensary cannabis has not been thoroughly evaluated scientifically, is poorly regulated and tested, and is frequently contaminated. Most research on the use of cannabinoids in pain are with products that are not available in the United States, or with synthetic cannabis-based medications, some of which are FDA approved. We should support the development of natural cannabinoids which meet the rigor of scientific study, just like any other medication. There is a large body of scientific evidence supporting that marijuana users are at a higher risk of developing opioid misuse or opioid use disorder. For instance, the #1 risk factor for adolescent opioid misuse is having ever used marijuana, and the predominant predictor of adult opioid misuse is using marijuana before the age of 18. Regarding other health impacts, the American Heart Association paper from August of 2020 concluded that people who use marijuana may be at higher risk of sudden death, heart attack, and stroke. They caution people with underlying cardiovascular disease to avoid marijuana use. The ISAC Library is a wonderful reference for anyone interested in learning more about the use and effects of marijuana in many medical scenarios. Thank you, and I will now pass to Dr. Catherine Antley, Secretary and Treasurer of ISAC.
Thank you, Dr. Finn. My name is Catherine Antley. I am Secretary Treasurer of ISAC. I'm a medical doctor, pathologist, and laboratory director. I share my colleagues' concerns about the increase in cannabis use and the impacts we're seeing. ISAC has assembled world leaders in the field of cannabis-induced illness and addiction. I would like to highlight the work of one of our leading advisory board members, Sir Robin Murray, professor of King's College London, who's one of the world's most respected authorities in the field of schizophrenia and psychosis. While cannabis impacts health in many different ways, perhaps the most devastating, is its link to psychosis and schizophrenia. Regarding this, Sir Robin Murray states, no serious scientist continues to dispute that cannabis is a component cause of psychosis. The evidence goes far beyond association studies. They're randomized controlled studies, they're genetic studies, they're animal studies, they're complicated designs which strengthen the case of this causality. Importantly, scientists use these same criteria to determine smoking is not just associated with cancer, but causes cancer. Just a few data points. Nearly half of patients who present with cannabis-induced psychosis will convert to full-blown schizophrenia or bipolar disorder with psychosis. Their psychotic thinking does not necessarily clear when they stop using. Many of these individuals are left hearing voices, seeing hallucinations, or having paranoid delusions, even without continued use of cannabis. Greater use of more potent products results in higher incidence of psychosis. The active ingredient in cannabis, THC, when given to normal volunteer groups, creates psychotic symptoms in the laboratory. The majority of patients who develop psychosis or schizophrenia using cannabis have no family history of schizophrenia. In some cities, 30 to 50% of patients who present to psychiatrists with first episode psychosis have, in fact, cannabis-associated psychosis resulting from their regular use of just 10 to 15% THC. These patients would be well, but for their cannabis use. Parents call me all the time. Last year, a mom called to say that they had spent all of their retirement savings treating their son's cannabis addiction. And yet today, he's still using, tormented by voices, hallucinations, and believing paranoid delusions. He's still suffering. And that family's still suffering. Marijuana addiction and diseases that can result from its use, like schizophrenia, are devastating and also difficult to treat using rehabs, medication, antipsychotics, or therapy. Public health scientists have known for decades that drug treatment is the least effective, most expensive way to deal with an epidemic of addiction, which now touches 1 in 3 American families. In 1964, when medical scientists finally linked smoking to cancer, there was public outcry. And as a result, in the following years, warning labels were required in packaging, advertising was banned on broadcast media, and an ongoing annual review and report was ordered by the Committee on the Health Consequences of Smoking. We saw tobacco use decrease. Unfortunately, now we're in the storm of increasing drug and cannabis use in the US. Yet, when implemented scientifically, proven and effective prevention methods have been shown to decrease addiction across substances reliably and consistently across cultures and socioeconomic groups. Prevention is possible. With cannabis, this type of effective prevention must begin with a frank discussion and acknowledgement of the negative health impacts of cannabis use. Thank you, and I now pass to Dr. Renette Lev.
Thank you, Dr. Antley. You provide a compelling example of psychosis, a subject that people can learn more about on our ISAC website, iasic1.org. We will provide a link in the chat. We're very proud of the ISAC Medical Library. It is available on our ISAC website and contains peer-reviewed medical literature about marijuana or cannabis that's translated into terminology that allows for informed decision-making by the general public. Let me take you on a tour of the library. It is organized by categories, and each category has summary statements, expanded summaries, and links to the medical reference. There are many categories, from addiction, allergies, autism, to seizures, violence, and withdrawal. The library provides definitions for cannabis versus marijuana and industrial hemp. Let's look at an example. We are now on the ISAC1.org website under the tab Library, And if we look at the categories, we can select the one that says cancer. Clicking on cancer, it takes you to a statement. Testicular cancer is associated with over twofold risk of marijuana users. If we open that tab to expand, there are 3 articles that back up that statement on testicular cancer with a summary and a link to the original medical research. We provide this library free to the public, as well as a resource to both health professionals and drug prevention specialists. We want people to be informed decision makers. Today, if you pick up a cigarette, you know the risks of cancer, emphysema, and addiction. You may be asked to smoke away from others. We want the public to know the risks of marijuana with addiction, psychosis, cancer, autism, secondhand smoke, and more. If you choose to use, you may be asked to do so away from kids and not get behind the wheel. The mission of ISAC, the International Academy on the Science and Impact of Cannabis, is to provide education by doctors. I will now pass to Joe Eberstein, who heads the San Diego Marijuana Prevention Initiative.
Thank you, Dr. Levin, and thank you to the doctors for this much needed public health information. I'm the program manager for the San Diego County Marijuana Prevention Initiative, and I'm with the Center for Community Research. I work with youth to educate about marijuana harms. Over the past 5 years, San Diego County has seen an increase in marijuana poison control calls, emergency room visits, treatment admits for youth, and lung injuries due to marijuana. I very much appreciate this new ISAC resource. We in prevention are consistently told by public officials and politicians that we do not have enough medical literature on marijuana harms to support policies that limit youth access and enhance public health. This new resource puts that myth to rest. This easy to navigate website will help inform our community. I want to thank ISAC for this resource and let people know a link to the ISAC library is on our website, ccrconsulting.org/MPI, and it's also in the chat box. Thank you. Now to Dr. Levin.
Thank you, Joe, and thank you to Dr. Eric Voth, Dr. Ken.
Oh boy, so
Finn and Dr. Catherine Anthony. We want to inform the medical community on the science and data that is available today, and we want the public to be informed decision makers. The public hears about miraculous cures of cannabis and CBD without the science and data on the risks and harms. And unfortunately, I see some of these people as patients in the emergency department. ISAC brings science and data to the risk-benefit calculations of using marijuana. All our physicians who spoke today can be contacted through our website, ISAC1.org, IASIC1.org. And we will now open for questions.
Hello, everybody. Joe passed it back to me, and I'm going to do 1 second.
yeah, I just wanted everyone to see that, not only are treatment professionals and prevention speaking up, but, legitimate doctors with no political agenda other than to get some public health and consumer protections in place before we continue to open this market up. And I will tell you that Dr. Antley's speech on psychosis was the first time I was hearing a lot of that. It was very compelling and very scary. And leading into that, Patrick is going to talk about co-occurring disorders, mental health disorders, and cannabis use. Patrick?
Hey, everybody again. A big part of the substance use disorder field is working with co-occurring disorders. People integrate into treatment and diagnosis come up. years ago, probably in 2008, I would say, we would have drug treatment on one side and we'd have mental health professionals on the other side. And what we were doing is we were making cross referrals to both, okay? What they decided to do in the county of San Diego was brilliant, which was to take the substance use field and the mental health field, and they merged them together. So part of these contracts, which was really important, was the fact that I could treat somebody for substance use disorder and then refer them into the next office right next to me to the mental health professional. And that saved lots of time, energy, and also made sure that the clients that we were working with weren't falling in the cracks, meaning missing, some substantial treatment for their condition, which is very serious, and which we take very seriously. So I'm going to focus on some of the most prevalent conditions that we see as a result of some substance use when it leads to dependence, and years of it, and here we go. The first one, generalized depression that we see on a regular basis, social anxiety, thoughts of suicide, suicide attempts, the actual, finding out that someone actually went all the way through and committed suicide, psychosis, paranoia, and schizophrenia. I have something that I want to talk about in regards to suicide, and that is that if you know somebody that's struggling, not just from 2020, but coming into this year, if it's a friend, family member, or colleague, and you haven't heard from them in a while, make plans to go hang out with them. Send them a text today. Call them, see how they're doing. And what we find is that people that are isolating with all the stuff that's going on with their co-occurring disorder in regards to substance treatment, they're very, not just overwhelmed, they're at a total loss of what to do and how to do it. So, I want to make sure that, you guys are reaching out to the people that you know. And I do the same, and so does Joe. And mental health disorders, in regards to CUD, it seems that the users significantly are more likely than non-users to develop a temporary psychosis and or long-lasting mental health disorders, including schizophrenia. And Joe touched on this a little bit, but the first time I heard schizophrenia and marijuana in the same sentence, I didn't say no way. I said, no, I could see that because the paranoia that sometimes they experience and the anxiety they experience from smoking marijuana. Now, sometimes the users claim that it's during the actual smoking, like I'm getting high right now, I start feeling that sense of anxiety and that deep feeling of that. But this onset schizophrenia means that they did not have it either in their family tree or they did not have an existing co-occurring disorder, and it developed from the massive use of marijuana. I spoke of polysubstance disorders, and it seems that cannabis users tend to like to do hallucinogens, and hallucinogens are extremely dangerous. One-time use could mean permanent, mental health for lifelong. And in regards to schizophrenia, it's a lifelong condition that obviously self-talk therapy, seeing psychiatry, and those types of things, just lifelong. I actually don't even know where it comes from, but it's very overwhelming for everybody that it touches the sufferer. And simple mental health disorders that we've been working with for years: depression, anxiety, chronic anxiety, chronic depression. I can't seem to just get the day going, or like I say, a lot of the times the people who are suffering from these disorders, it's like riding a bike with no chain. They just cannot get through the day or get started with the day. Warning signs of mental illness. Great slide that this is. This is kind of like, red flag when they come into treatment in regards to that we need to hook them up with the mental health therapist that we work with. A lot of the times what we see with marijuana, chronic marijuana use, is a lot of ADHD, either prior to marijuana use and then during the use and then after their use, and a topic that is a little taboo. Therapy is taboo. Seeing a psychiatrist is taboo. Hey, I don't want anybody knowing. But one that's rarely talked about is actually taking medication, right? So for ADHD, which I commonly see a lot with adolescents, this treatment includes medication, talk therapy, obviously support groups, CBT, which I'll cover in a couple slides, is the cognitive behavioral therapy. A big one, here it comes, anger management and the structure of an anger management program, which this happens all the time. The person that's referred for anger management always says, come on, man, I don't need anger management. I'm not angry, right? Sometimes anger doesn't come out as screaming, shouting, and as such, right? Counseling, psychoeducation, a huge component is family therapy, and then the last is applied behavioral analysis. In working with teens that have ADHD, I seem to find that they like to self-medicate with marijuana because it helps them cope with their attention issues that they have, right? And one of the best descriptions that I found of ADHD came from a psychiatrist who's an expert. He said, when people have ADHD, it's like the lottery balls. They're flying around, and what they're trying to do is put a sentence together. So they grab one of the balls, they grab another, and then they can put a sentence together. Now you add 6 years of chronic marijuana use to that, sometimes they're struggling with just daily activities. And that is this: getting up on time, showering, brushing their teeth, making their bed, eating on a regular basis, meaning that they forget to eat and then they wonder why they're so tight all day long, or they're anxious. And then what they eat, they tend to, my experience with one-on-one, they tend to eat a lot of fast food. It's stuff that's soothing to them. It's comfort food, right? And the medication that's primarily used to help them is a stimulant. So there's a question of these people, ADHD, ADD, and giving them a stimulant when they have a substance disorder. So the biggest thing for us as a treatment provider is to get a consent to talk to their psychiatrist, psychologist, and their therapist, and be extremely involved in those conversations to say, you're dealing with somebody that has a substance issue, so we want to be careful to not overprescribe or watch closely with a stimulant. So I would say the CDC website talks about that about 70 or 80% of people that have ADHD and a substance use disorder are prescribed a stimulant drug like Adderall. And I have found that a lot of people abuse that drug. And another thing is that sometimes that's to be used for work and school. And they tend to use it when they're not at those functions. I think something that's dangerous is when you tell somebody on a prescription that you take 1 in the morning, or maybe 2 in the morning and 1 in the afternoon, or as needed. What I find with people who are substance abusers, they tend to read prescriptions backwards. So instead of 2 every 4 hours, it tends to be 4 every 2. So we want to be very careful that we're monitoring that medication, if that's with loved ones or if it's just one-on-one therapy, that we're counting the medication. These are things that I've done many, many times. And with depression, it seems that a lot of people are prescribed an antidepressant, of course, but really talk therapy, attending one-on-one sessions, trying to do some kind of CBT where they're taking the past and they're realizing it, and then what they can do today to empower themselves. And I made this slide, being open to change, having an open mind to new experiences, saying, hey, your age doesn't matter what it is. Let's say you're 28 and it's okay to use medication for a period of time. One of the biggest things we learn in SUD treatment in regards to mental health therapy together collectively is that sometimes therapy is not forever, and we say that therapy is it's not a forever thing, it's a right now thing, and it's what they're learning while they're there, and it's possible that short stint in therapy could change their life forever in a positive way. Another disorder we talked about on that first slide was a psychotic disorder, and in regards to massive marijuana use, I've experienced this working one-on-one with my life coaching. where a gentleman, he was attending school, and he obviously had to drive there. He had a car, and I got a call from him saying he really needed to see me. So I made plans to see him that night. And when I got there, I noticed that his car was in the parking spot, which is where he always parked. And he went to tell me a story that he had went to school that day and that somebody had followed him home. So he wanted me to help him move his car to another spot. And I'm going to keep the story very simple, okay? This whole story was something that he hallucinated, and he doesn't do any drugs except marijuana. And that time I asked him, I said, so what did you do in the last 48 hours? And he happened to be smoking weed all day the day before, and in between smoking high concentrated leafy green, he was eating edibles. And I believe in that moment he was having a psychotic episode because he was talking about people that were following him. And he actually told me, and Joe actually knows of this story because I pitched this before, that it wasn't just people, but it was a specific type of person that had red eyes, and that they were following him home. So they were reading his license plate, and I'm listening to all this, and the first thing I'm thinking about is, did he do something other than marijuana? And what it sounds like is did he do some kind of methamphetamine or an amphetamine, or is he on some kind of hallucinogen? And he ended up having to be hospitalized. And here is the other part of the story. So I get him down to the intensive inpatient location, and the woman that's doing the actual interview, I'm sitting there with her. I identify who I am and my experience. She's listening to the story, and then there was a moment there where she wasn't going to admit him. So what I did was I asked if I could talk to her outside with his permission, so he didn't think that I was telling her secrets. And I said, here's my suggestion. You admit him before he has a psychotic episode at his house, because he's believing that people are following him. And all of this was a psychotic episode because of too much high-grade marijuana and in a 2-day period. So he gets admitted, and I got to tell you this part of the story, because this is how addicts, alcoholics, and people who suffer from mental health disorders. As soon as the psychotic episode passes for him, he's in a lockdown unit where he can't get out. So Joe knows where I'm going with the story. He calls me and he says, hey, how you doing? I go, good. He goes, well, look, man, like I'm not high anymore, and will you come and see me? I said, sure. So I go see him, and he's sitting at this table eating their little box lunch. And he goes, hey, this wall over here is only about 12 feet. So will you give me a lift over the wall, and I'll just meet you at the truck so I can get out of here? And it's funny in the ways that even in his worst moment, he's still telling me, trying to convince me, hey, let's hop the wall, we'll get in the truck, and go eat some pumpkin pie and everything will be okay. And I said, actually, no, you need to stay here. Now, there's some other truth about this story. That the reason why I'm pitching it is because he really needed to stay there. But after 72 hours, he said all the right things because he had been in a situation like that before. So because he answered all the questions that he needed to answer with the psychiatrist that was on shift, they couldn't hold him anymore. So he went back out into society. Now there's another part that I'm going to tell you. He went into inpatient lockdown because of marijuana use. I picked him up. I took him back to his house. But guess what? I'm not going to stay with him for over 24 hours and sleep there. I got to go back to where I live. And in that same day, he started getting high again. So it's kind of a process where it just continues to circle. One of the therapy that works amazing with therapists, with especially substance use disorder, cannabis use dependent, is CBT. And what it seems to, the theory of the change when the therapists work with them is learning to modify those dysfunctional thought patterns. And once they can understand how to modify the old idea with a thought, a feeling, a behavior, they can do the change plan as well. So leaving treatment and saying, what am I going to do different today? It starts out with very small steps, but turns into something extremely greater. Because guess what? I've said this to many people that are in treatment. When we're looking at you're here in group today, you might not be here next year. So you're not going to be sitting in front of a structured facility, right? Where Pat, the director's there, Joe, the therapist, is there, and we got filled the substance use disorder with all this support. And then here, let me name another one, a case manager, somebody's title who is to help you get your license, get you, you know, a job, you know, help you make phone calls that you could make, all for people. So what we're going for is we're trying to help them in that CBT therapy to learn how to cope when all the structure's not around, right? After the wraparound service happens, because people say all the time, well, what happens when all this goes away? We hope that we've helped them and given them tools in their bag so that they can actually go back to normal living, or what they feel is normal, okay? So the role of the therapist with substance use disorder counselor is communication. This is why this actual piece of paper, a consent for treatment and consent to communicate, is huge. While we're teaching coping skills, they're doing the same. But what we want to do is actually come together as one. So my structure, their structure is molding, so we're on the same page, right? So if I see that there's a relapse, I can call and say, hey, I got a positive test. Make sure he's getting in touch with the psychiatrist, because he's on Adderall or he's on that depression medication, and he can't be using, or she can't be using at the same time. So the therapist's goal is to help me with that structure, bridge the communication, but also why they're not in actually therapy and they're out at their house and they're not in group with me, they're given some kind of homework assignment. This is brilliant. So it's saying, here's what I want you to do for the next week. For the next 7 days, I want you to write down everything you do hour for hour, including what you eat. And someone goes, okay, I can do that. Because then it's going to show what that person does for 7 days, which eating, sleeping, all these patterns help. That 8-8-8 in a 24-hour period, it helps the therapist, you know, get through the therapy that they're teaching, but also it helps us with what we're trying to do in substance goals. Okay. So the goal for CBT treatment is to learn that negative patterns of thought, evaluate the outcomes of those things, and really try and replace it with positive outcomes, positive thinking, and in a really, really simple terms, healthier ways of thinking. So instead of always this, everything's bad, what happened to me in the past is terrible, I can't see the forest through the trees, I got to come up with some kind of tools, coping skills, so that when I go get that job, or even better, you guys, when I don't get that job, and life tends to kind of give you the, you know, when it rains, it pours, right? And you thought you had a tough year, and all of a sudden it's like, whew, my car got impounded, you know? They teach them things to help them cope with those problems, where, you know, for some people, that stuff's easy. It's like, oh man, my car's not going to get impounded because I paid the registration and the insurance and I've made my monthly statement payments. But for people that are going through substance use treatment and they're in therapy, sometimes even paying insurance is tough to do. Register a car, they haven't done that in 10 years. This is true. These things I've learned. And there's going to be a beginning, a middle, and an end to CBT. So the beginning is to, like we do in sub treatment, establish a safe and supportive relationship. And then they're going to complete like a functional analysis, a breakdown set of paperwork, and then educate and explain CBT, and then set these collaborative goals. So it's working, right? And in the middle, that negative thought pattern, uncover it, assign homework, really focus on their mood and their behavior, their feelings, and then really try to remove not just negative things, but also labeling things. So we want to stop that. And I've learned this from therapists, to really learn not to label them of stuff that maybe someone that they're really resentful at, like their dad or their mom or their grandpa, has been telling them for years. And then they're having some kind of cross-transferencing group with you because you're not on board. That's why I'm saying this communication is important. I check in with therapists on a weekly basis to see where we're at, especially if the session is going to help me help them. And then CBT, the end. Yes, you're identifying skills that are learned. You rehearse certain situations. And then, you know, you talk about the future struggles, right? And here's one. I say this to people all the time. If you're thinking that you possibly were going to relapse back to your drug of choice and that was going to mean ruin for you, tell me what you're going to do and what is something that you couldn't, you'd be so overwhelmed with that you wouldn't know how to deal with it. And they'll tell you what that is. And I had a guy tell me, you know, I've had this dog for 12 years. And when that dog dies, I don't know. I don't know what I'm going to do. And I asked him, is it possible that if the dog died that you're going to be okay? It's just going to be extremely painful and your feelings are going to be overwhelmed, but you can walk through that. In that moment, that pain's going to be so great, but it's going to get better one day at a time. And he said, no, it's not possible because I'm never going to feel better, right? So it's all of the things that usually worked. And what we got him to do is to realize, you know what, it's going to be okay. And you know what he did? Here's the truth. He didn't buy another dog while that dog was dying. He didn't buy a dog after his dog passed away. He walked through it with dignity and respect. He cried, he talked about it, and he didn't have to drink or use drugs or harm himself or anybody else. To this day, he still doesn't have a dog because it's a lot of responsibility to have a little puppy, you know, or even have a new dog. I'm going to go through DBT, behavioral therapy, but I want to kind of talk about this. Treatment consists of medication and therapy. So treatment could usually be lifelong depending on your diagnosis, and it can often involve a combination of medication, psychotherapy, and some kind of special care. Not all therapy is going to be lifelong, but some conditions like ADHD, right? You might have to check in with your therapist. Maybe you do therapy for a while and then you don't do it anymore. Maybe you check in with a psychiatrist for medication, and maybe you don't. Maybe you do a whole different approach. You do meditation, prayer, yoga, gym, whatever it is, free writing, poems, those types of things. I've seen a lot of things happen. But the combination of the both, it works hand in hand. It seems that you can do one without the other, have therapy without the medication. But for people who have done it and it doesn't work, sometimes they really struggle with the thought of, I have to take this pill every day and I'm different than other people. And one thing that I've seen many times is that people don't want to feel different or than the other person. They don't want to feel like I have to be, just to be okay, I have to take this medication. And sometimes that's a lifetime experience of them and doing with that struggle. So this is what I've taught many times, is that sometimes it's a 1 day at a time program. Your life is 1 day at a time. You're only guaranteed 24 hours, and that's just one little pill. So your day is bigger than that little pill. So maybe just for today, you take that pill, you know, and until they don't want to do it anymore. And I've met legions of people that stop taking it and they do other things, as long as they're staying spiritually fit. So if you're a substance user and dependent, and you know therapy works, then if you're still going to 12-step programs and you're taking care of yourself and you're living healthy, it's possible that 50% is just medication, the other 50% is on you. So if you're doing more work on yourself, maybe you don't need. But it's an individual case by case. So dialectic behavioral therapy, the theory of change, happens through mindfulness, skills to manage any kind of distress that comes, trying to regulate your emotions, and then really trying to prove that that communication and problem solving. And sometimes it's problem solving with anybody who's in your path. That could be coworkers, that could be loved ones, but really trying to learn, emphasize accepting uncomfortable thoughts instead of struggling with them. That maybe it's okay that the things that happened to you in the past, and I keep bringing up the past because it seems to be that a lot of people who are substance users, they live there a lot on past experiences and trauma, and sometimes it's because that's all they have. That's what makes them who they are, you know. Just like CBT, the role of the therapist, it's to validate your feelings, which sometimes people have struggled with. I worked with a client. They were the middle child, and they weren't the firstborn, and they weren't the baby, and none of their feelings were ever validated. Nothing they ever did, it didn't matter. If you were having overwhelming feelings, oh, whatever, you know, suck it up. You know, you're going to be all right. You know, you're going to act like an adult. You know, crying's for babies. You know, all these old ideas, and it's like, well, hey, man, my feelings are valid, right? So this really works with people who struggle with the fact that maybe they didn't have the same support their siblings did. And then that's okay that they're not sitting there, you know, crying about it or pouting their feet, but or stomping their feet, but this really helps them. Big part, coach treatment. Coaching them through the goal, right? Checking in with them, making small goals to get to the big goal. I'll give you an example about goals, okay? When we're talking about goals, we're talking about if somebody says, I want to graduate from San Diego State University, and I don't want to do it in 4 years, I want to do it in 2 years. I don't know if a 4-year degree you can get done in 2, right? So what we try and do is set up the little goals of, how about just this week in the next 3 days, call the counselor or call San Diego State and get that up there, and let's talk about that. And I know I don't think you guys know what I'm going to say, but I can tell you how many times I've had that person come back in 3 days and say, how'd that phone call go? What phone call? Oh, yeah, San Diego State. Well, I'm going to call them this week. So those little goals are really important. So instead of putting on a goals list, you know, we're going to get through 4 years of college in 2 years, we say San Diego State, bachelor's in science, criminal justice administration. Boom, there it is. Now, how do we get there? You know, one step at a time, one day at a time, one section of change at a time. And I really feel like once people put down any kind of substance, they give themselves a chance. They have like a different or an open mind. They use therapy and the growth with loved ones. I've seen a lot of families reconnect and they live beautiful lives. And those things are attainable. And I've seen a lot of people say, really cut themselves short. You know, I know a guy, he's got 12 years away from a drink or a drug. He still goes to therapy. And he said, if you told me that I would have what I have today 12 years ago, I wouldn't have believed you. And here's the most important part, which these types of tactics helped him out with him, is he said that I wouldn't have wanted those things. You know, I didn't want to own the keys to a car that was my own, or have an apartment or a condo that I owned, have a bank account that's not a negative balance. And he said, man, bank account, I didn't even have a bank account, right? I mean, these are things that in 12 years he's gotten back, but therapy really helped. And in regards to any kind of intervention, sometimes interventions come when people don't want to change, you know? And what we find is that how high is your pain tolerance emotionally? Like, how much pain do you have to endure, self-inflicted pain, and until you're ready to change? And sometimes it's to each his own. It's the person, you know? So the struggle within is, how do you change and be okay with yourself on a day-to-day basis? You know, on top of that, doing your laundry. And the things I'm going to say is because I've watched people struggle with this. On top of dealing with real life situations in therapy, they have to do their laundry, go to work, put gas in the car, and man, my phone's dead because I haven't charged it today. Jeez Louise, you know? These are the certain struggles that people deal with in sub treatment and therapy. I like this pitch right here. How to ask for what you want and say no while maintaining self-respect and relationship with others. What helps SUD users with this is that they tend to be a people-pleasing community. Their heart bleeds for wanting to help people, so they say yes to everything, and then they have to go back and cancel 4 things because they forgot that they committed to 7 things on the same day. And I've experienced this myself, and trying to keep it simple with saying, you know, I can't do that right now, but if anything changes, you'll be the first one that knows. Now, that took me years to master that, you know, because I'm thinking that I got, you know, like I said, I got a 24-hour day, right? I can fit a lot of things into that, but guess what? I end up running myself rampant, and I'm not taking care of, you know, simple tasks. How to change emotions that you want to change. Sometimes people don't want to change certain things, so that's why we focus on one thing at a time. Great image right here. So many different things going on. This kind of looks like an ADHD brain where your arrows are going all over the place. And what is something that they can change? Sometimes it's an attitude adjustment, which is very tough. Think about all these things that are in this picture. Pandemic, words like COVID-19, social distancing, lockdown, isolation, coronavirus, quarantine, lockdown, isolation, and it goes in a circle. You know, how do you change and deal with that when it seems like everything's pressuring you, and then you got your boss calling you saying, hey, you're going to be here in 10 minutes, we got to start this meeting, you know? And just like DBT and CBT, there's all these homework assignments that people get to take home. So whatever they're struggling with, they're trying to go, you know, step by step with the actual assignment. If they come back and they don't do the assignment, this happens in SUD all the time. We give, you know, simple tasks. you know, sometimes there's an underlining something else is going on. But I like the assignments that are at home because then they're not in front of peers, they're not in front of other counselors, and it's something that when they come back, it's usually closed door, one-on-one, where you're talking to them about it. Last but not least, I think the beginning phases for this is moving clients out of control to achieving behavioral control. Not lashing out irrationally. Maybe they're not throwing chairs. You know, when they're angry, they change things. But this takes a lot of time. So in substance treatment, again, it's a revolving door of work. It's the sub counselor working with the therapist working with the client, the therapist talking to the sub counselor, and we're all working together. And if something comes up, you know, emotional stress, something, loss of a job or a new job, and we see some behavioral change, we all have to be communicating for the benefit of the client. And that also means that it's possible a psychiatrist has to be involved in this conversation. So I thank you guys. I appreciate your time. I've left my information on the PowerPoint. My phone number's on there as well. If you have any questions that maybe are private that you didn't want to ask in front of everybody, please reach out to me on my email. And thank you very much. I'm going to pass it back to Joe.
Wow, what amazing information. We're going to transition a little bit to prevention tools.
Welcome to the Isaac.
We talked about some treatment tools, a lot of treatment tools. We're coming into the home stretch here. And for those of you who have lasted this long, I really appreciate it. I hope you really are getting something out of this. So let's talk about prevention. A lot of states are going to have to deal with this type of change. And, you know, federally, they're considering changing the scheduling of marijuana, which for those states that have no access at all, including medical, is going to be a huge, huge transition. What I get from people who, you know, are kind of negative on prevention is the idea that prevention doesn't work, the lack of resources or manpower. And our opposition is well funded. They are. Compared to us, they got the media on their side. And then for prevention, we really can't decide what works best. You know, we know what doesn't work, and just say no types of things. Unfortunately, they were meant to do well, but they didn't really work. So I think using facts and evidence, you know, prevention around marijuana can feel like this on a daily basis, especially dealing with kids who have very strong opinions about it. The issue has been politicized and is polarizing. There doesn't seem to be a middle ground. And then really strong views. And then you have the issue of cannabis use disorder. The person doesn't realize that they have a chemical addiction or a chemical substance use disorder, and they don't realize it. And because there's no rock bottom, then, you know, they don't think it's a problem. We have to battle the perception that everybody feels that everybody's using marijuana on a regular basis. You know, when you look at the actual studies, most people don't smoke marijuana on a frequent basis. Nationally, about 14% of the population admits to regular marijuana use. So when somebody says, well, you know, you don't know, everybody's doing it, all my friends are they really? Or are you just hearing this, you know, from the media or from social media? You know, a lot of people don't go around saying, hey, I don't use marijuana. So you're not really hearing that side of the story. This idea that prevention doesn't work, you know, look, I know what my job is. My job is to keep that developing brain healthy before the age of 25. Now, what you do after 25, I can't tell you, but the science says you should probably stay away from these substances. We don't ever say prevention doesn't work around cancer, heart disease, diabetes. I mean, prevention worked perfectly for tobacco use. It did until they introduced the vaping devices. You know, your idea of prevention may not work, or what you've been doing may not work, but I think if you use some of the tools in the toolbox that I'm going to show you, it can work, and we don't ever want to give up. I really love this saying, true prevention is not waiting for bad things to happen. It's preventing things from happening in the first place. So I use facts, I use my story. And again, I'm not ashamed to say I'm an alcoholic. Patrick's not ashamed with his battle. And I think people want to see people with lived experience. We have to keep recruiting partners, doctors, nurses, paramedics. I mean, I think that media event that I shared was so powerful because it wasn't crazy, lunatic, anti-marijuana people. It was just doctors saying, hey, we need to take this slowly and consider some of the public health effects before we start selling this stuff like candy. That's really what I got from it. I didn't see a bunch of fanatics in that. I just saw a bunch of concerned doctors stating research and science. We need a diverse representation. Again, if somebody comes to me and says, Joe, you are not representative of my community, I say, well, then take the information that I give you and go represent your community. I mean, none of us are going to be representative of every single community. So take the information and relay it back to whichever community. I mean, if I use that, I'm an openly gay man, I wouldn't be able to do prevention in schools that were predominantly straight. I mean, I just don't use that. I go in and I say, you know what, I'm good at what I do because I use a little bit of humor, I use a lot of facts, and I relay my story. And I have never once been told, you are not like us, so you can't do prevention in my community. I've never heard that. I've been working here in San Diego, predominantly Latino population. We have a mix of everything, to be honest with you. And I think if you put your heart and soul, as you can see Patrick and I do, in your work, it can transcend that. And then you have to have partners that are willing and have the time to advocate. We have a key leadership team. It's not just Patrick, it's Dr. Lev, you saw her. We have researchers from UCSD, Dr. Joanna Jacobus. She's heading one of the largest longitudinal studies on brain development in the history of this country, called the ABCD study. I would look it up. They're looking at things like social media use during adolescence, substance use, your environment, and they're doing brain scans to see how these different things affect youth. So go look it up. It's called the ABCD Brain Cognitive Study. We got to start prevention early. As I've said, 10 or 11. We don't have to start with the specifics like I did, but I think keeping an open ear. I can remember being back in middle school and having a friend say, I heard that Johnny got caught with something. And I would go home and talk to, who was ever there and say, Johnny got caught with this. And then somebody would usually say, oh, that. So let me tell you what that is. That's how it really starts. It's not like one day all of a sudden you start thinking about substance use. And now with the phone, it's access all over the place earlier. So just be prepared for those conversations. You should know a little something about each of the drugs, and not just say, hey, you know what, don't do it. It's really bad for you. Try to provide some facts. The discussion starts at home. I have parents come up to me and they say, what else are you doing? You can see that we're involved in a lot of things, the drug interactions, the Isaac group. I'm speaking all over the place, but you have to do your part at home and keep open communication with your kids. Be aware of any subtle changes. If you find paraphernalia, that could be a huge indicator that something's going on. Check their phone. Friends can speak up as well. If you're at a party with your best friend and they're always agreeing to do something and somebody offers them a pill, there's never been a worse time with fentanyl. Speak up and say, don't do it. It's not smart. If you're looking for an actual curriculum that's school-based, you can go to DEA Operation Prevention. It's an actual modules and learning objectives, and it's science and fact-based. Coping strategies. A lot of the sidebar conversations that I get when I would go in and do parent nights or, go into schools, from the kids, I would hear, I'm sick and tired of being sick and tired. I must be weird for needing help with just weed. I'm going to lose all my friends when I quit. And this is a big one because many people, especially when it comes to weed, marijuana, they develop friendships around use. And when you ask them to quit, they are really reluctant because their entire friend base is based on using marijuana. So what strategies, Patrick gave you a few, are you going to help the child cope when they lose a lot of their friends? What do I do with all this time on my hands is another big one. What are your hobbies? If you were drinking like I used to drink, it takes time to go get the alcohol, to pour the alcohol in a cup, to get drunk, then to go over the hangover. That takes a lot of time. So now that you took that away from me, what do I do with all this time now? So introduce some healthy hobbies, maybe the gym, maybe jujitsu, maybe whatever it is. A big one too is I have anxiety. How am I going to deal with stuff? Lots of our kids have anxiety. Excuse me. And then from concerned parents, I get this. I did it as a kid. How can I be upset about it? I mean, I just showed you how different the products are. I mean, you got to know this isn't the 3 to 5% THC that was used in the 80s. This is 90% in a vape pen, causing psychosis a lot earlier, and the urine drug tests are showing it. Do people really seek treatment for marijuana? Can you just talk to him? Maybe he'll stop. I get this one quite frequently too. I cannot talk somebody out of marijuana use if they've been using for the past 11 years. Having a good talking to is not going to do it. You might need some other treatment options. I'm worried about the changes I'm seeing. A lot of parents will say, I've seen abrupt changes over the last month or two. There is a complete disinterest in the things that Johnny used to like to do. His grades are falling. I'm seeing brand new items. I don't know where he got the money for this. Or I found some kind of weird paraphernalia, but he said it was only liquid nicotine in a vape pen. That's another one I hear. Any sign of a vape pen, I would be concerned. Always keep an open ear. Make sure you're seeing any changes in friends, any changes in behavior, sleep patterns. Prevention means limiting phone access. Now, me and Patrick did have a conversation about this the other day, and it was really, well, you can't stop kids from having a phone. I didn't say that. I said parents need to think about when they're going to give a phone to a child with a developing brain. And what are you going to give them access to? What are the limitations? Because once you get a phone, you are substantially increasing access to substances and also to all of this. You're going to start with the body image problems, with the pornography nonstop, social isolation, gambling, depression, politics 24/7. Are you prepared to talk about these issues to your 11-year-old or your 10-year-old? Because the phone opens this all up. And I always go back to the statement here. I love this. Are our brains evolving as fast as our technology? So using the tools in our toolbox, I want to show you some of the things that we're doing to combat retail sales and normalization from a public health standpoint. Number one, you can create a website. I know people have this image of, oh my gosh, I got to create a website. I don't know anything about tech. I don't know how to do it. Well, it's very easy. You can go to several different easy website packages. There's Wix, there's Site 123, there's other ones. Excuse me, I'm going to shut this door so we don't hear this phone. And you can create a really nice website that's pretty cheap financially. So, and it can have all of your materials. It can house all of your TA that you offer, and it's easy to do. Um, Develop your own materials and resources and reports, your informational handouts. Make sure your social media links. One of my pet peeves is when I go on and I see that these supposedly active news feeds haven't had a brand new blog on it since, 1985. It's like, please keep them somewhat active. Make sure your links are working. I mean, people are seeking treatment. They need help. If they're ready to go and start searching online, the last thing you want to do is come across a link that doesn't work. Make sure there's youth participation, accurate info that's culturally appropriate. We developed info cards. Some people would say, info cards, my God, that's barbaric. It's like, well, when I started 12 years ago, there was no information about vaping. There was no information about what edibles do. There was no information about spice. And we had to create all of them that were local to San Diego. I mean, this was before Colorado went legal. This was before Washington did. There was very little information. And you can go and make your own information cards. I mean, when you go to these events, you need to hand out something when you have a resource table. So I know some people say, oh, there's Joe, the info card guy. But do you want to sit at a table at a resource fair with no resources? So go to Vista Print. You can get multiple sizes, you get multiple paper types. Make sure again that they're culturally appropriate. Here we have a large Spanish speaking population. Most of our information is in English and Spanish. We want to reach everyone in the community. We have a marijuana specific lease addendum for people who don't want to be around marijuana smoke in their apartment complexes. This was done post legalization with housing attorneys. It covers both medical and recreational use. One of my pet peeves is going home and smelling high-grade marijuana with my asthma. It triggers it. I don't like the skunky smell. And I want landlords to know they don't have to put up with it. They can have a lease addendum. Even showing this lease addendum to a person who smokes marijuana, it may be enough for them to say, this apartment manager takes it seriously. I may go to the next apartment. If you're a property owner too, marijuana is not kind to your rental property. It gets into the rug. It gets into the paint. It smells up the place. And if you're growing, there's mold, mildew, electrical problems. I mean, some places that we thought were rented out to families, there was an actual grow in every room of the house. So it can really damage somebody's property. A school nurse protocol. We're getting asked now in several schools, can the nurse administer non-FDA approved marijuana edibles to my son? And it's like, no, the nurse can, because we don't know where you got this product from. The nurse wasn't ever trained to administer gummy bears to a 5-year-old. And can you get maybe one of your home health aides to administer it? I think it puts too much liability on the school and the nurse. So we came up with a recommendation sheet. You should have fact sheets like this that are about what medical societies have said. Again, we created all of these, and I'll say there's really 4 of us on our team. And for a small 4-member crew, we really pack a punch. And Dr. Lev by herself packs a punch. She's got a podcast. She has the Isaac website, and she's also our chief medical officer. So one person can make a difference. Working with traditional media is a nightmare lately, especially when it comes to marijuana. They never want to carry any marijuana related news if it shows marijuana in the slightest bad light. And they're fixated right now on COVID vaccines and politics. We've had some great media events and nobody from the traditional media picked it up. It's just amazing. So you know what you do? You create your own podcast, your own YouTube page. Go to social media. We have a social media presence as well. I've been on Instagram, Snapchat. Make sure we're reaching the kids. Some of these were 15-minute question and answer sessions, but it was fun, and hopefully we reached a different audience. We have an active YouTube page. This costs us nothing to have a YouTube page, and it gets around working with traditional media. The last one, the drug interactions event we did, no media showed up. So we had to go and video it by Facebook Live. And the funny thing that happened? We got a bunch of print media after it based on the Facebook Live event. Dr. Lev has a High Truths podcast because she was sick and tired of the regular media. So she's always having prevention groups. She had Dr. Nora Volkow on there not too shortly ago. So she's always looking for different groups that talk about prevention, talk about substance use, fentanyl, and all of those, any kind of treatment related stuff. I wanted to share this because I don't have any affiliation with Recovery 2.0, but I often go on YouTube to see who's talking about quitting marijuana. This was one of the most non-judgmental videos I've ever seen from an ex-marijuana user. There are 600,000 views, and if you read the comments, over 3,000, it is eye-opening how many people want to quit, how many people are having trouble quitting. So go to this guy's name's Tommy Rosen. He just lays it out in such a factual way. You really can't argue with him. And generally, when anybody's talking about anything, that isn't favorable to marijuana, they get shouted down or nasty comments. This guy has very few nasty comments on his page. Start a drug driving campaign. Our state didn't do it, so we started Put Drug Driving on Your Radar. Right before legalization, we knew was going to happen. We have rallies and drug driving week. We visited the drug driving lab at UCSD, where they're currently studying new iPad-based sobriety tests. Very interesting stuff coming out in the field of sobriety testing and drug recognition. Map out your marijuana storefronts, know where the locations are. Generally, they're supposed to be separated by 1,000 feet from any youth-sensitive location. We want to make sure they're maintaining that and not breaking the law. So maybe have an interactive map that maps out the locations. Know where to file a complaint. In California, it's with the Department of Cannabis Control. In Illinois, it's with the IDFPR, and you can file a complaint right there. It looks like they're going to be creating a new website. I hope they are, because the one that I was looking at for this presentation just seemed like it was a lot of stuff that didn't seem to be what I was looking for. There should be an easy way to see where the complaint section is. I really had to search for it. There is marijuana tax revenue going back to prevention. And I used to sit on the group that allocated some of these funds back in 2019 and 20. Now, the amount of money that's trickling back does not in any way exceed how much money it's costing us in public health. And you could see that through the entire presentation. The cost of legalization far outweighs $29 million in 2020. And they're making billions of dollars. What is harm reduction around marijuana? Well, one of the things I'd like to see is the age limit to be 25 across the board. There should be potency limits. There definitely needs to be warning labels and consumer protections. What does it look like? Maybe weaning off of some of the more potent stuff in favor of the less potent stuff. If you are going to try marijuana for medical purposes, go to a real doctor like your primary care physician and ask them about it. You can join groups that support individuals trying to quit. We're not going to go to questions. I'm going to go into fentanyl and take us right home and do questions at the end. I have to talk about fentanyl because fentanyl is a huge issue that's taking a lot of lives. And this is the first year we saw 12 and 13-year-olds. So fentanyl, as many people know, is a powerful pain medication. It's an opioid pain medication, and it is being found now in OxyContin pills. And it's so dangerous that the DEA had to put out a fact sheet and a health advisory. An alarming thing they found were that 2 out of 5 pills that were found in San Diego to contain fentanyl had a lethal dose. So that's playing Russian roulette. The public safety alert they put out in September, this is how concerned they were about these blue pills containing fentanyl. You can create your own fentanyl information cards. We have, these are at bus stations and billboards around the county. Make sure your school district has a naloxone toolkit. Naloxone is the overdose reversal drug. A few things about naloxone or Narcan. It's used along with emergency medical treatment to reverse life-threatening effects. Oftentimes, multiple doses are needed. Always call 911. And there's an insert that goes with the Narcan. So people ask me all the time, can it hurt if you give it to somebody multiple times? No. It may be repeated every 2 to 3 minutes, and it can be repeated without harm, but always call 911. Here are some other resources I'm going to be pointing out. We did a best practices literature review in San Diego around what prevention programs work and why do they work. A few of the components that seem to work were reducing youth access, developing community coalitions involving multiple sectors, providing mentoring programs and promoting healthy role models, and you can read everything else. You can see in our initiative, we try to incorporate many components of this. We do have a central location for our prevention community that the schools can access. This has always been one of those issues. There's so many resources out there. Where can I access all of them in one place? We have Live Well tools for schools. If you want to create this in your communities, you can do that. When I do prevention, I know that we're the first line of defense. And I'm really trying to stick to the facts. And I can use humor and I can use science. To me, it's not about slogans and scare tactics. I don't ever go into a school and start showing crash videos of DUI or any kind of carnage. It's just not the prevention I do. You know, I tell a little bit of my story. I use a little bit of humor. You know, I use a lot of facts, and then, you know, I go in multiple times. Again, this is the first line of defense. I'm not saying prevention is the be all and end all. It's just let me inform you so you can make a better choice. You are a prevention resource. So get knowledgeable, learn as much as you can, take public speaking courses and practice. I used to be so afraid of public speaking. I never thought I could get up in front of an audience and do this. I mean, the first time I did something, I went down in flames, literally. So every time you do it, you get better. I do a lot of talking to myself on the side to prepare, whatever makes you feel more comfortable. I write myself a lot of notes, you know, and practice makes perfect. You know, I said this in the beginning, I want to say it now. You have to be inclusive in your work. And I'm going to just tell you, personally, from my own story, I'm an openly gay man. And, you know, I know people struggled during COVID, but I know the gay community struggled a lot. And they struggled possibly with, you know, during this time, they were very isolated. Some of us don't speak to our parents. Some of us were disowned by our parents. People who were HIV positive, who have a weakened immune system, were walking around during COVID thinking it was their last day if they get it. There was incredible fear. There was incredible fear about accessing their medication. You know, so there were amplified effects in certain communities. The bars and the social gatherings were all gone. I mean, back in the 90s and 2000s, that was the only place I could find any sense of community. It forced us to go online, and online is not the same as in person. We have to meet with industry folks, and we have to get them to start talking about consumer protections. We have to reiterate, and I say this all the time, I'm not a prohibitionist, I'm not a fanatic. I just think if we're going to open up access, you want to make it clear that it shouldn't be around kids. You need to have driver warnings, mental health warnings, and maybe that age limit. Right now, you can get a medical card and be 18 years old in this state. It is way too young to be accessing these high potency products. Some of the things we're seeing that the marijuana industry promised they wouldn't do after retail sales was they're taking our local control away from us. They're allowing deliveries even in municipalities that banned retail sales. They're diminishing our public comment periods. They're trying to get away from some of the advertising federal bans on cannabis billboards on highways. Local planning groups are being ignored. It's a real problem. It's a real problem. And then you have the issue of the black market never goes away. And it hasn't gone away here. And as long as the black market is flourishing, it's always going to put a black eye on the legal market. And it's always going to take away the tax revenue from the legal market. I don't know what the cure is for this, but I know Colorado's black market hasn't gone away. Washington hasn't, and our hasn't. Consumption lounges, I can guarantee you, are coming to Illinois. The industry and lawmakers promised they wouldn't allow lounges and public consumption. And now what do you think they're doing? Consumption lounges. The licenses specifically allow smoking and vaping, but not in direct sales of cannabis, infused food, or drinks. What happened to our smoke-free policies that we worked so hard on? And what about workers being exposed to secondhand marijuana smoke? Do you have an access and crisis line? Where do people who need help, are they able to reach somebody on the other end? If you don't have an access and crisis line, I would suggest getting one that has central resources. And make sure that there's a human being that's ready to talk at some point. Some people who are reaching out are at their wits' end, and maybe you are the voice that they hear on the other end that's going to steer them in the direction of treatment and resources. We're here to help. We're not here to judge. I'm not here to judge. Patrick isn't here to judge. We wouldn't be able to do the jobs we do if we were trying to judge. We try to meet people where they are. And, a lot of people are struggling now. So what I tend to see, because I have marijuana using friends, and I can only speak from my experience with my friends, is there's a real trouble coping. There's a failure to achieve milestones. What do I mean by that? My friends who smoke a lot of weed are doesn't seem like they're in successful relationships. Their jobs are always changing. They're usually complaining about something. I'm not happy. I'm not this. I'm not fulfilled. They really report a decreased quality of life or a dissatisfaction. And I don't think many of them can associate that with the marijuana. Some of them do. And some of them at a point say, I need to quit. And the problem is when they've been doing it for 10 years and they know this isn't easy. As Patrick said, if you've been using for a long time, it might take a few weeks for your dopamine levels to come back to normal and all of your chemicals to come back down to normal. But the good news is they usually will. It's just going to take that really anxious time to get over. I want to let everybody know about this free virtual summit. There's 2 of them. The Western State Marijuana Summit, November 2nd to the 3rd. There is registration. It's free. It's virtual. That's November 2nd and 3rd. And then November 4th and 5th is the Western State Opioid Stimulant Summit. And that's also virtual, and it's free. And CEU's credits are available. So on that note, this is my email. I'll take any questions that anybody may have. I think Orlando's still on with me. Let's see if we can get this up. And I see 10 people still lasted with me the whole time. So Orlando, do you have any questions? Are there any questions?
As of right now, there's no questions, but I'd like to thank you and Patrick for the wonderful presentation these last 4 hours. It's a lot of work.
Well, I appreciate it, and thank you again for having us. You know, Orlando, my team is here if you need us, and I will share our PowerPoint. As long as it's not too big to share, I'll figure a way to get it to you. Okay. I'm going to sign off.
Okay. Thank you, Joe.
Okay, you have a great day and take care. Patrick had to leave. He says thank you and have a good weekend. Have a happy Halloween.
Happy Halloween. Happy Halloween, everyone.